for people that have SMI. We're doing the basic stuff. We're doing the BMI and the weight, the BP and the pulse. We're asking about alcohol consumption and smoking status. But the most enriching thing is about that conversation that we have with people. That's, you know, when we ask about, are you looking after your health? Have you got any aches and pains? Are you brushing your teeth? What about, you know, letting you know if you've got a low blood pressure? So it's not just doing those checks. It's that conversation around it that helps people to hopefully think about themselves, help them to have that behavioural change in themselves, because John had made that behavioural change, you know, by not going to sleep, by not drinking, by trying to stay up. And because he was informed, because he knew what he had to do, that actually helped him to change his mindset as well. And so when people do that, they then start to take charge of their own health, because they start to understand why some physical health things happen. And that actually what John said to me, well, I was just getting older, Jane. And actually things happen in our bodies, not just because we're getting older, but there's usually quite a reason why that happens. So it's having those conversations with people and digging a little bit further. I think one of the things that he said to me was that when we invited people for these physical health checks, we used a particular kind of language, and, you know, it frightened people off. People were like, no, you're going to want me to stop smoking. I know I'm overweight. You're going to want me to go on a diet. I'm not doing that. And so people avoided that. And so we changed the language and the way that we invited people to come and have their health checks. And that has since increased. We're a long way away from getting to the 60% national target. I admit that as well. But we're getting there. And I think we've got to think about how we improve this and what the opportunities are, because the short term for John was that he got to see his GP, he got to have a blood test, he got his bowel kit and he actually used it and sent it off. Otherwise, that had still been on top of fireplace. And the long-term stuff is about understanding the value of national screening programs and what it is that's coming through your letterbox, understanding your physical health care, because he you know, he didn't realise, a lot of people don't realise that they've got choices, you know, that they can make choices for themselves around their own mental health and physical health, and that we've got better health outcomes for John now. So he's, you know, he's phoned me twice more since that conversation in middle of summer, and I keep asking him what does he want to do, and he's like, I think I might want to start some exercise, Jane, and lose a bit of weight, because I'm, you know, my trousers are getting a bit tight for me. So he started to make choices for himself and do things without prompting and without any support from other people. So that means that it becomes more sustainable when people are motivated to do things for themselves as well. So that's kind of like one story of a person that would have just sat there, would have sat with a problem with his prostate, not even thinking that that's something that he could remedy himself, and that by going to his GP could have been actioned. We don't know what the outcome is yet, but we know that in terms of his health outcomes and how he sees his future is a lot better, and he's actually engaging more with people now as well. So that's just one example of how a physical health check can impact on a person's overall physical health as well. I think there's still things that we need to do around that. I think we need to think about how we quantify this and how we gather people's experiences are having physical health checks and what people think about their own physical health checks. I think we need to think about the language that we use. And, you know, I spoke to one lady, the same clinic actually, that didn't know the difference between constipation and diarrhea, you know, so changing that around for people as well. And I think there's also something about when I've spoke to John on several occasions, he certainly made me think about what I need to do in future. So that co-production, working with John to make sure that whatever we produce in future, such as this information leaflet that we've done alongside people from Primary Care Network, when people are coming into GP practices, that we look at the language that we use and how we engage with people as well. And also, you know, if we're asking people to come and co-produce with us, that we can look at what future recommendations are as well in their own physical health, because a lot of people think that it's not their responsibility, it's somebody else is going to do that for them, and that they don't have any choices. And actually that's as far from the truth as what as what's right. So I don't know, Patrick, if you wanted to add anything more into that.
I think you're right. I think there's still an awful lot that we need to do, but we have made quite a lot of progress, certainly on the outcomes for people with SMI. But I think there is still quite a bit that we need to do to reach at least the 60% target and beyond.
Yeah.
Thank you so much, Jane and Patrick, for just bringing that insight into this conversation today about the importance of language. I think it's so important, really, that the language that we use in so many different ways, even the meeting today, I guess, but the language that we use is sort of personal, and it's connecting with people, and that provides people with the confidences, really, that to take that first step, because even just picking the phone up is a huge step for some people, and feeling confident that they, going and having a good conversation. And sometimes, I guess what you said, it's getting your role, others' role, in getting alongside people in that sort of space to help them to have that sort of conversation, guide them along the way, really, throughout their journey, in terms of understanding their own physical, their own body, actually, and different things that might happen to their body over time, really, and not be scared about having some of those conversations. It really is a big step, really, and those wraparound conversations, really, that are so important for people. But I guess others might want to reflect as well on your story that you brought through today. I'm aware that there's been quite a bit of work on this, hasn't there, James and Dave, between primary care and Swift?
Yeah, massive. I mean, we're doing some work with primary care networks around physical health checks. It's called blue boxes, and they've got equipment which is Bluetooth, and it's looking at people. We need to go much further. We need to allow people to take responsibility for not only their own physical health, but checking their own physical health as well. So, using new digitalization products that we've got, so that people can become empowered and take ownership of managing their own health.
Absolutely right. Leslie, Dave, and then James.
Thank you. Leslie DeBell. I'm non-exec member on the ICB. Thank you for that. That's just so powerful, and actually so reflects the conversation Kirsty and I were just having at the start of the meeting about real people's lives and the impact of what we do in terms of somebody's real life. So perfect. I agree with you about the language that we use and sometimes the approach that's taken. And I'm just reflecting really on how great it is to hear something that's working with and alongside people, rather than so often the perception is that things are going to be done to people, and people's perception themselves is that things are going to be done to them. So the thing about you're going to make me stop smoking, you're going to make me lose weight, you're going to tell me off, kind of thing, I think is really important to remember, because that can be a barrier to people arriving in the first place, can't it? And I just wonder how John, wasn't it, might feel about kind of being a bit of an advocate for things, because sometimes somebody telling their own story, somebody saying to you, well, I did it, look, and they weren't like that, and it wasn't like that, is really, really powerful. So, I wonder if we can get some champions in that system to actually tell other people about a different kind of experience and alleviate some of those worries that create barriers.
Really helpful.
I think I've already coerced him into it. Every time I phone him up now, he's like, yeah, all right then, Jane. And I've said to him, I'm going to use your story as an example for other people. And he's gone like, oh, okay then. And do people want to meet me? And that kind of thing. So it's opening new doors for him. And I think it's about having that belief in people as well. You know that you can make decisions for yourself. This is about you, and I'm not going to do for you. They were a worry right at the beginning that we were just going to bring people in, do the physical health checks, and then say, right, see you in a year's time. But actually, we can do that. That's the easy bit. The hard bit is about when people say, well, actually, I do want to stop smoking, or I do want to stop using illicit substances, and I want support for that. And how are we going to manage that and monitor it? Because we need it to be sustainable. Any life changes, however significant they are, need to be sustainable for that person as well. So there's plenty of people I'm not worried about getting enough testaments and narratives of people about wanting to share their testaments, because that's what's important, and that I think is what we need to take forward in how we change and improve what we do by people's own experiences.
Yeah, absolutely right. Dave?
Yeah, it was just a couple of things really, just to follow. I suppose, part of it was just to pick up on the kind of so what bit of the health check. So, yeah, because the case study kind of data and the kind of qualitative data around patient experience is obviously really important. So that's sort of stories that Jane's gone through will always be important to us, but we're also kind of trying to look at some of the harder data around health outcomes, which seems particularly pertinent, bearing in mind that, of course, the reason for the target in the first place is that people with serious mental illness have worse health outcomes than the rest of the population typically. So we are interested in trying to track that. It's about trying to just be clear how we can capture some of that on a medium and long-term basis. So that's quite important. The other bit was just to say that it is about, I mean, I think in the instance that Jay mentioned, it was about particularly connecting someone with some follow-on activity around their physical health. But of course, there are issues about how we use the health check to connect people with other resources, with social prescribing resources, for example, in local communities, and really kind of connect people with the kind of the community assets. So it's quite a broad piece. So it is about actually the quality of that health check is a really kind of important issue, and that's not just about ticking off the domains of a health check. It's about how it actually connects that individual to a range of other assets and options that will support their health and well-being in the kind of broader sense.
It's really helpful, and the insight, I think, from this work about what's missing, what people are finding that they want to access that isn't around, so that it can really feed nicely into the work that we do in the Stronger Communities team, for example, in the council, about what else do we need to start to build in terms of either other types of activity, if it's physical health activity or emotional support or anything else. I think that cycle of conversation is so important. James.
Yeah, I was going to say some of the stuff that Dave's mentioned around that interconnectivity with the sort of wraparound services and how you then take that forward. But also I think in terms of linking with the primary care network, it's around making sure that everyone's getting the same consistency of service as well, so that it's being done in the same way across each, across each neighbourhood, across each GP practice. So we're looking at how we tackle those issues and make sure we're not leaving it neighbours or people behind, which I think is really important.
That's really important, James. What we've found is that it's not happening. So we haven't got that standardised approach as yet. So in Swift, we measure cardiometabolic assessment that we have on System 1, and what we're checking for is what were defined by our sequin. If we look at in GPs, it's defined by QOF. People that sit on an SMI register is defined totally different as well. So we're trying to bring all that together, because the people generally are the same kind of folk. They live in Barnsley, they've got similar kind of diagnosis, so chances are that they've got similar kind of physical health problems as well. So we just need to bring that all together and tie it all together. I am reassured that we know these people are, whether they sit with GP surgeries or whether they sit in mental health services. So I'm really hopeful that folk aren't going to get missed, James, and that we are going to get there. But there is some disparity in what we collect and how we collect it. There is that. So we're working really closely to try and iron that out as well.
Really helpful, thank you. Madway?
Yeah, just excuse the disturbance in the background. Can you hear me okay?
Yes.
Yeah. So just reflecting on what Jane said, there is a bit of a work with regards, how we do collect the information collectively, and it is sort of reflective of what it is across the patch. So there is equity for all patients. But also what I wanted to sort of tap into is, yes, the usage of language, but also, these are the most vulnerable patients who have a lot of anxieties. And we did a piece of work within the practice for the people who are non-attenders, who do not want to come in for their reviews on a regular basis. And what we've done is tapped into the resource of care coordinators we've got, who were then ringing them to establish a little bit of rapport. And actually, they went in to bring them in to the practice. So they did a house visit and brought them in so we can complete the review. There were only about 8 patients we did this, but once they've come in and had that done, they've sort of were over the barrier, and it was sort of fear for some people. Some people didn't want to come in because it was COVID times, they don't want to catch the infection, and some people it's just I'm fine, I'm okay, I'm stable, I don't need this. So I think together, Jane, there is a piece of work that can be done, isn't it? Because it's sort of looking at models as to how we can, because people who come always come. It's the people who don't come.
That's true.
Yeah. So it's sort of looking, and it's little things which would make a huge difference to some of these patients. Yeah.
Well, one of the models that we're going to use is kind of like a triage model with the social prescribers, the health and wellbeing coaches that sit within GP practices. We're linking up with our peer support workers as well. So people are going to go out, they're going to get trained in the blue boxes, which are the Bluetooth devices, and the people that don't want to come into GP surgeries, these are people that are monitored through GP surgeries and practices. We're going to go out to them in their own homes with the peer support worker, and these peer support workers that we employed that sit within our mental health services that have their own lived experience as well. So we're trying to break down them barriers straight away as well, which is great. And I think the only other thing that I wanted to mention as well, I know somebody mentioned about longevity and sustainability, is what we also need to collect is around the financial return and investment as well. Wendy, you mentioned about the social impact it has, and it builds on resilient communities. This, you know, it connects people with the local communities because they start engaging more once they feel empowered and they start taking charge of their own health as well. But also that financial return as well. So things like, you know, it'd be great in future once we've sort of like created some sort of thematic analysis that we can start looking at things like reduction in medications, reduction in pain management, reduction in how many people are coming to the GPs for other things as well. So longer term stuff we can actually attach, you know, monetary values to that as well, which would be great, which is in the pipeline. It's not happened yet, but it will.
I think it would be great in due course to bring a summary report around the impact of the work in terms of people with severe mental illness and people with a learning disability. And let's have a look at that in due course. That'd be really, really helpful, Jane. I completely agree. So thank you once again. Thank you for the hard work that I know the Recovery College put in every day to support people in Barnsley with mental health needs. I know some very creative stuff that goes off in there. Hugely appreciated. So thanks again. And thanks, Patrick, as well.
Thank you.
Thank you. Cheers. Thanks a lot. Bye-bye.
Bye-bye. So we've left that go on a little bit. It's an important conversation because it's an important area that we need to see some continued, you know, development and improvement on. So I feel reassured from that. You'll not see actually on those that have joined us through Teams that we don't have any members of the public with us today. I don't think there's anybody that's joined online either. That isn't unusual. We're not an unusual place partnership that isn't seeing attendance. I think it's a pretty common observation. I think those that do want to turn up are generally joining the ICB arrangements. Those that used to join the CCG governing body, we tend to see them at the ICB board. But nevertheless, we will continue to ensure that the messaging about the partnership gets out there and encourages people to join us today. So we did have a little bit of time there to utilise for Jane and Patrick's contribution. I'm going to pass over then to item 5 to Kirsty.
Thank you. So for colleagues I've not met before, I'm Kirsty Wacknell. I head up the comms, engagement and equality team at the ICB here in Barnsley. So the paper I brought today, it's an involvement paper, which normally brings through things like the voice of Barnsley people and how they're using services, but we've got a slightly different focus this month. And we wanted to bring in some of the work that Jane and colleagues across the voluntary and community sector are doing, just to, I suppose, bring us to a place where we understand what's happening in Barnsley within that sector, and actually where Barnsley sits within the whole of South Yorkshire, because actually there is a huge amount of work going on, and it feels really sort of timely to be able to talk about that. So the context setting that I've got in this report, it's just to sort of provide a bit of an update, because actually, like I say, a lot of this work is happening and we probably aren't cited on a lot of it. Jane's clearly cited on everything, because Jane's at every meeting I think I go to on this agenda. So I'm going to hand over to Jane in a moment just to give a bit of an update on those two areas. But the reason we've put it in an involvement report is what I often hear, so working in engagement or involvement, when I hear people talking about the voluntary sector, it's often, oh, they're the people that can be the route to our local communities. And absolutely, you know, a lot of voluntary groups are set up purely from the need of their local communities. You know, they're not very often not national bodies, they are local groups that are born out of local need of local communities. And clearly they've got the voice of large chunks of our communities, and they're really valuable insights. But actually, Barnsley CVS and the VCSE sector are sat round the table as strategic partners, and also they have a clear role as being able to inform in terms of key providers around the table. So we've sort of done a bit of a double act, haven't we? We've put it all in an involvement report, but actually the involvement bit at the moment is probably the third on the list. of where colleagues sit around the table on this partnership. So with that context, I'm going to pass over to Jane, who's going to pull out some of the points of the Barnsley work and the South Yorkshire work. Thank you, Jane.
Okay, I'm Jane Holliday. I'm the CEO at Barnsley CVS. And as Kirsty says, we have our own infrastructure within the voluntary and community sector. So at the top end, if you like, all the leaders from the various voluntary sector support organisations. So that's Barnsley CVS, Bassett Law CVS jump in and out because sometimes they're with us and sometimes they're not. But also Voluntary Action Sheffield, Doncaster and Voluntary Action Rotherham, along with South Yorkshire Community Fund. So we're meeting very, very regularly to share information about what's happening, to get involved in how things are developing. But also the big part of that is going back to the VCSC network. So any organisation within the voluntary sector or the community sector is a member of the South Yorkshire Alliance. And so we're constantly sharing information and getting it out there. And recently, on the 3rd of November, we had a working together event, which I was very impressed because I thought it would either be sort of like all Rotherham because it was there, or all Sheffield because that's the bigger area. And as it turned out, we held our own, including Barnsley's voluntary sector leaders who turned up to hear about what is happening. So they've been working together for a while, developing the memorandum of understanding for the Alliance and also the terms of reference. So there've been a lot of involvement from the voluntary sector. And this sort of culminated in the event on the 3rd of November, and there were 100 people there. It was very, very good because, as you'll be aware from lots of meetings, a lot of it is still about process. And I thought that wouldn't go very well, but everybody was well into it. And particularly around the One Workforce initiative, I think this is something that is different and could have lots of benefits all around. So we've got our leaders group, we've got our alliance, which is right across the whole of the voluntary sector, and then we've got the Barnsley VCSC strategy group, and that meets every 6 weeks, and the meeting's in 2 parts. So the first part is an interface between the community and voluntary sector and statutory services, so that we can share issues that are coming up from both sides, share information. But the second hour is purely for the VCSE sector, and it's chaired by me. What I realise is that most voluntary sector organisations do not get time paid for to go to meetings, and so it is great that so many of them turn out for these meetings. So in the first half, we can hear speakers, we can have a chat about the issues that are coming up, we get information passed on about funding opportunities. Health Watch is a standing item on there. And so it's really, really helpful in terms of providing an interface. At present, any voluntary sector organisation can send a representative to this meeting. So if people want to raise something quickly, then this is a really good way of doing it. But as I said, the second half is more about what is happening in the voluntary sector. And we had a bit of an issue raised that I found really interesting around youth service, and it's a procurement that's been done some time ago, and there were strong feelings in the voluntary sector among providers that it wasn't necessarily meeting the needs, and they didn't feel like they'd been fully consulted in it. So we put a line under that, and now what we're doing is we're working together with the commissioners from the youth side and everybody involved, with whatever sector they work in, to work together in an alliance to make it better going forward. That's a massive step forward, and it just shows that when we all sit down we're free to raise our issues and we start talking together, we can get on and create real change. So we've already got Barnsley Third Sector Dementia Alliance, which brings together 6 voluntary sector organisations, provides great extra value because they're pulling money in mainly from outside of health and social services. So it's really helpful. There's a migration partnership in Barnsley, and we've got Barnsley Older People's Physical Activity Alliance that is drawing together. Well, there are 55 providers working together on a falls prevention agenda. So this is really what I think we're really good at in Barnsley, and this is more of what we want to see from the strategy group. So the idea of the strategy group is, as I said, at present, anybody from the voluntary sector can attend, but going forward, we expect the group to grow too big to manage just one meeting. And at that point, we will theme them so that they are around starting well, living well and aging well. And then that overall meeting will become a representative meeting from those groups. It's brilliant because one of the things that the voluntary sector complain about is they haven't got a lot of time. So newsletters that go on and on about everything are a particularly irksome thing. So the plan is to make sure that everything that we do is more targeted in the future. So people are only getting the information that they need and therefore responding to it. And that's it.
Thank you, Jane. So I think that gives a really good overview, doesn't it, of where we're at, and actually all the stuff that sits behind, particularly the Dementia Alliance and the Migration Partnership and the Older People's Activity Alliance. Actually, you know, there's 100 papers that sit behind that we could talk about the value and the scope of work that they do. But I think, well, there's one thing for me that you mentioned there about the bringing in funding for that sector, and actually us understanding, you know, the added value and the social value of all the work that's taking place out there. Actually is probably something that that we haven't brought back through to this meeting, and there's something about that for me in the future that I think we need to do. So, you know, so we get a view of the whole, actually. So yeah, so take any questions.
Thank you, Jane. It's really, and it's really great that that strategy group is really starting to gather some momentum now. It's been sort of, I guess, long overdue, hasn't it, in many ways? So, you know, thank you to you and your leadership about stepping into that space, because I think without that, I'm not sure we might struggle to make the headway that you've been able to make in that space. I mean, any particular questions at all from colleagues? Yeah, Leslie?
Yeah. Thank you, Jane and Kirsty. That's been really helpful. I am aware of kind of, you know, what's been going on in Barnsley. Obviously, on another day, I'm working in the voluntary and community sector myself. And I think it's really great to see things that are developing, what it seems quite fast as well. So that's really good. And I agree with you about looking wider at the value, Kirsty, of the voluntary and community sector. You know, the leverage that is created in terms of bringing funding in. But I think when we're making that assessment, we also need to look at actually the contribution, if you want to cash it up, in terms of local people's input into that. You know, people's time is a valuable resource. It's not just about pounds, shillings and pence, if you're as old as I am, but it is about, you know, every day in every way, people that live in Barnsley will be putting stuff into that, their time, their expertise, their experience that is really valuable, and it is great that people are turning up at things. I agree with you, Jane, that we've also got to not stress that resource too much. So it needs to be targeted in those ways, because actually people have only got a finite amount of time. What we don't want to do is turn people off from it. So doing what you're doing and finding your way through, that's really key, I think.
Right, and it was really helpful to see some of the commission. I think it was you, Roxanne, that shared it, wasn't it? The commission that I think it was it? Yeah, Humber Coast and Vale. That's right. Humber Coast and Vale had done some really interesting work, and they'd done a bit of a commission around the economic value of the voluntary and community sector as a partnership in and of itself, really. And I don't know whether you've seen those slides at all. Can we share those slides, please, with Jane and Kirsty and Leslie as well? I'm sure you'd be interested in seeing those, really, because I think it's getting to that point, isn't it, where we really need to start to, certainly for the ICS and for place for us to think about in the context of our the strategic priorities going forward, what actually space and partnership arrangements do we want to get in place, really, for working with VCSE? Because we would hopefully expect, as we know, more money over time flowing into preventative type of investments and less in the acute end, of course. So, so thank you for that update. There is also, partners, there is also a set of slides that were produced within the council, but I'm conscious I don't think they were shared more broadly, about the breadth of alliances that we've built in Barnsley over the number of years. James pointed to a few of them, but it's quite a rich picture, I think, and it's probably helpful for partners to see that. So I will share that with everybody. I think that'll be quite useful set of slides. They can be obtained from Phil Hollingsworth, Kay, if you could ask him for those. Okay, is there any particular ask, Jane, at this moment in time from the place partnership, from the VCSE strategy group?
Anything to feedback in particular? We've just got a new engagement officer that is working right across South Yorkshire, and her name is Louise. I forget her surname, but you will see her around, and she'll be really useful in terms of helping us to reach into the sector, but also in terms of putting it all together and feeding it back. So we're really excited that she's landed. And no, generally we just the memorandum of understanding is probably the next thing that needs to be finalised. But no, it's all coming together really well.
Thank you. Thanks. Yeah. Oh, sorry, Adrian.
All the things that we've got an issue with, and that's the gapping services and volunteers and non-charitable organisations not registered that we don't know about. I think that's where we've got to start picking those up. And the way to do that is to work with the neighbourhood.
You know, as we continue to build our neighbourhood-based arrangements in a collaborative way, so we recognise the assets there. Sometimes they're individuals, aren't they, working out the front room?
The effect on the local population is significant.
Yeah, completely agree. Okay, so thank you again. So moving on to item 7, declarations of interest. I think this is just an update. I think we're bringing in around the declarations of interest. I think we had some observations, didn't we, historically, around some amendments we needed to make. Liz, I think you made some. Hopefully this is it. Are we okay with that? Jane? Sorry, Jane.
Jane Sivakumar, Chief Nurse for Barnsley Place. It's just, there are 2, Roxana and my job titles are the change. They've been done. I've got the page this morning. Brilliant. Thank you.
Yeah, on top of it already. Yeah, so hopefully then that's the final version.
Yeah, sorry again.
Adrian?
Seem to have missed off the circulation list. I don't seem to have received that request, but it's possibly because of my emails being corrupted.
Oh dear. Right. Okay.
So that's why I'm using CVS all the time. The other thing, with the obvious one for the agenda today, is that I'm the independent chair of the MHA. Item 12.
Thank you. All right. Okay. Thank you very much. So we're now on to the minutes of the previous.
Wendy, you've got Richard wanting to ask a question.
Sorry, going blind. Richard.
Hi, Wendy. Hi, everybody. Yeah, just really sorry, but mine should say Joint Chief Exec of the Rotherham NHS Foundation Trust. It just says Interim Joint Chief Executive.
Right. Okay. So they are the final changes, I think. Then we can get this off our desk. So some final amendments there, if we can make those changes and recirculate, please. Thank you. Anything else? Any further offers on the declarations of interest? No. Okay. Item 8 then. Okay, minutes of the meeting on the 29th of September. Can we agree those as an accurate record? Yeah, okay, thank you. The actions arising from these. I think that's the action log case. There's a dedicated action log.
I think the action log, you could just a private section because it's got some other actions on there as well as actions from the private session.
Right,
We can
okay.
sort that.
We sort that. Okay, then we'll just have a quick look through in terms of the action. So I'm on page 2 of the minutes. I think we dealt item BPC 4, that's dealt with, isn't it? BPC 6. Hang on, let's keep going down, scrolling down. We had an action to embed updates around the integrated care partnership on this agenda. That's on. Sheena, you're covering that off, I think, aren't you, on the agenda, which is really helpful. Thank you. And we had an action there, if you see it further down, Leslie, the committee noted the ongoing work on assurance and work.
Yeah, Jane and I are going to pick that up on the
Quality
quality
item.
item.
Thank you very much. And we said to include a glossary for members of the public in the place committee. Done.
Yeah, that's been done.
All actioned. And I think that's it. Do you want me to cover off? I can cover off Marie, then any further actions noted on the partnership part of the meeting as well. But you can't keep carrying on. We had an action there from the Barnsley Place Partnership Board, noted the update from the Barnsley Place Delivery Group and the agreed action to produce a formal report, Jeremy.
The agenda.
The agenda, right, thank you. The dashboard, an action there further on about the dashboard. Obviously, we've got that on the agenda anyway.
I think completed.
Completed. And then a final one was just which we've done, extended in terms of the duration of the meeting. So I think we can note that all the actions from that meeting have been completed. Done and dusted. So moving quickly on, place director update. I'll keep it pretty brief. Some of this you'll be familiar with anyway. Loads of attention, of course, on the autumn statement, as we know, collectively across health and care. Obviously, quite a bit of conversation in the ICS about the autumn statement and how it sort of lands alongside, I guess, the Confederation and, of course, in terms of the local authority. It I think it'd be fair to say the general reflection, I think, from most people is that the announcements financially are helpful and will contribute to some of the pressures, but by no means all of the pressures, really. And I think the continued work that we'll need to do around our transformational efforts will continue to try to make the most of the Barnsley pound. We continue to do the work around supporting those that are most vulnerable. I think, again, linked to the autumn statement, I think challenges will continue for some of our individuals and families across our communities. So I did want to again say thank you to all our partners for the great collaborative work that we've been doing around more money in your pocket, the great work that I know you're all doing in your organisations around those folk that perhaps earn less within your organisations and what we can all do to support them. And indeed, of course, supporting key organisations. And thank goodness that we've invested in terms of Citizens Advice Bureau through the Stronger Communities work as well. So we've got good offers around debt advice and support across our neighbourhoods. And of course, sadly, we do continue to see working poor, don't even like the term, but working poor really probably being the greatest population that accesses the food banks across the town. So obviously continue to support the food banks to do what they need to do. We know that the integrated care strategy is in development, and I'm not going to cover off what Sheen is going to probably mention in her update, really, but we do know that there is a current public engagement out at this point in time for people to give a view about what matters to them in terms of their health and well-being. So again, a nudge to encourage as many people to complete that as we possibly can. And that will sit alongside the 270 pieces of engagement, I think, that have already been captured as part of that work. We had great attendance, Adrian, didn't we, at the launch of the Mental Health, Learning Disability and Autism partnership recently up at Shaw Lane. Really good take up, both from local place leaders on MHLDA alongside people that are working with the provider collaborative and people that are leading the more of the long-term plan transformation within the ICS, that team. That was a really good kick-off towards continuing to develop.
After that, Chair, and
yes,
on
please
December
do.
the 19th, there's going to be another get together to follow up from that. Progress it.
Excellent.
The LDNA coming in.
So that's it's really great. Just a couple of other things really. I think the provider collaboratives are starting to gather a little bit of momentum. Got a lead in terms of the primary care collaborative now. James has been appointed. Richard, you know, in terms of the acute collaborative, or indeed, you know, Bob, I think that's starting to gain a bit of momentum. We did note that there was an opportunity rather that's coming out, that has come out around the provider collaboratives, almost like trailblazer. There's an opportunity for any of the collaboratives, I guess in North East Yorkshire, to put forward a proposition around, I guess, going further, faster, be more transformational. There's only going to be, I think, 7 to 9, is it 7, 8 of those opportunities available, and there was quite a lot of a discussion within the ICS about whether or not we should just sponsor one of our collaboratives to put themselves forward. And we came to the view yesterday that actually, irrespective of the outcome of those submissions, that we would want to see any of the submissions that come forward from our collaboratives, because within all of that, thinking and consideration will be transformational opportunity, and then we'd want to get alongside that. So I think that was a really important sentiment that we heard yesterday. So I'm aware that mental health learning disability autism are going to be provided collaborative are submitting a bid, if you want, and I'm sure, you know, others are as well.
Just add to that as well, Chair. It's important that we take that in to note at place, because we want to avoid duplication with those provider collaboratives. We're very, very careful how we go forward with the collaborative and those, but that going away.
Yeah, completely agree. So a couple of other things really. It's just on the local level, I am just really conscious that the partnerships that we've had so far this year have been so very heavily weighted on governance and getting ourselves up to speed and up and running. So you've signing off, and we've been proposing a number of sets of terms of reference for our subgroups, all sorts of things like that. It's been a necessary space, I'm afraid, we've had to occupy. Because fundamentally, over time, if we want to be a weight-bearing partnership that takes more delegation, we have to make sure we've got our governance strong and purposeful. I think we've got to the other side of that now. I know we've got a couple just to have a look at today, but I think nearly everything now has been signed off, more or less. Somebody tells me otherwise. I think we're actually probably further on than any of the other 3 partnerships in that space, personally. Thank you, I guess, to all of your exec teams, so finance colleagues, performance colleagues, quality colleagues, chief nurses, everybody I think's really come around the table and collaborated on the terms of reference and membership. And thanks to Kay and Richard and the team, really, about Paige and colleagues, really, because there's been a lot of hard work, I think, to get us to that point in time. And I think that effort's really well appreciated. 23, we're off running, and we need to then start to make those subgroups count in terms of their activities, really take us forward. Final other thing really to mention then is really about, you know, we are doing a bit of a check-in in terms of the capacity that we've got within the place health and care team, and we'll be able to bring forward in probably January, I would think, January 23, a clear picture around the portfolio leadership that we've got across health and care. I'll share that with you in due course. And that's it. That's probably it from me. Otherwise, you'll be sick of hearing my voice. Anyway, so without any further ado, I'm going to, have we got Julia in now at all? And is Andy joining us for this?
Supposed to be.
Supposed to be. Okay. I think, given that we chase up, but we have to send them a bit of a Teams message page to see, you know, where they are in terms of.
He's working at ED this month.
So it might be a bit stretched, somewhat. What time is it? I am, yeah, a little bit over. So whilst Paige is just following up to see when they're able to join us, shall we move on to the quality and safety report, Jane?
Okay, so thanks, Wendy.
So yeah, is it? Oh, in the back.
There he is.
There's a seat over here, Andy, if you want to.
Is that? Well, how are we doing it? Are we standing up or should I?
Talk to down the screen.
I've got the slides.
Got the slides?
Yeah,
Yeah.
Paige has got the slides.
Slides up.
Oh, brilliant. Okay, thanks.
So hot out of a
A busy A&E
A&E
department, so I
department.
apologise for So we've got people up there as well, have we?
Yeah, so we're joined by Richard, Madway, Marie from Swift, Dave Ramsey, Carly Speechley.
Great. Well, I think, do I know everyone? So I'm Andy Snell, I'm public health consultant, and today I'm in A&E. I think that this is now kind of a bit of a two bits tagged on together. So we thought we'd do a quick rundown of health inequalities and the approach we're taking in Barnsley. But because of two reasons, one, we're bringing that back to this group in more detail as in the plan going forward in January, and because we'd also done some recent analysis on general health and care pressures, we thought we'd only very quickly go through the health inequalities approach and then talk about the health and care pressures analysis. So on to the next slide. So some of this might be a bit kind of teaching people to, whatever we say, suck eggs. But I'll just talk quickly on the inequality stuff around what we're meaning by inequalities, the actions we're taking already, and then this consolidating the approach into a plan. So next slide. This is all pretty high level stuff. Are you controlling the slide?
No.
Oh, I see you've got, this is good, yeah.
In case your eyesight's not that
Go
good.
on again, yeah, on again. Sorry, I've put too many introduction slides in this. So this is just a very quick reminder, and I think it is important that by health inequalities, we mean something that is what people in Barnsley are experiencing day to day. There's all sorts of ways to measure it, but this kind of looks at some deprivation measures. And I think, although it's a national chart, the two charts at the bottom right are the most important. If we look, there's all ways to think about inequalities, which I'll go on to briefly, but if we look at deprivation itself, and I'll explain what that means, across the kind of 10 deprivation deciles using IMD, then there's a very clear, still now gradient that tells us on the bottom right-hand chart that the more deprived you are, and that's not just financially, it's socially, environmentally, and other measures, the shorter you will live, and the longer you will live in that life in ill health. And the chart to the left of that is very important because it shows us that over the last 5-10 years, those things have got worse for the more deprived. So the 40% more deprived in our population are getting, their life is shortening and their length of life lived in good health is worsening. That is important because it is all related to everything we're trying to deal with here. So everything that is driving essentially, ultimately down to kind of health and care pressure. So the two things are quite related. And the division between Barnsley as a more deprived place than other parts of the country is massive, which is what the kind of line from white table shows us. And the division across Barnsley, of course, is massive. So we know the bus journey of life expectancy, but it's very true to acknowledge that these things that we can really measure and use to identify people do predict how likely they are to become poorly, how likely they are to become poorly early and die early, unless we do something about it. And then finally on the left is just telling us that rather depressingly, things are getting worse for the whole population across this country for both life expectancy and healthy life expectancy, but that's affecting populations like Barnsley more than anywhere else. So it is an important thing to consider. It is part of, in the long term, how we sustainably manage demand. So if we go on to the next slide, I won't dwell on this because we haven't got time to, but it's we'll go into this sort of thing in the plan a bit more. It's a bit kind of, so what do we mean by inequalities? There's lots of things that can drive it. The kind of three overlapping circles at the top left, just a one way to cut it. We're talking about who we are from a point of view of our age and sex and ethnicity. We're talking about who we are from the point of view of our social and economic circumstances, which lends itself to the deprivation angle, which I'll mention. We're also talking about who we are from the point of view of other characteristics, which we know are sometimes make us subject to exclusion or inclusion and discrimination. And that might be sexual orientation, it might be learning disabilities or other issues. Those are all things that we need to start understanding when we kind of plan health systems, plan care delivery, and actually make clinical decisions if we're in that space. Because they lead to everything we're seeing in the previous slide. There are some guidance, so we know about Core 20+5. It is massively challenging in Barnsley because if you look at the bottom left bars, that tells us that 21.3% of our population live in the most deprived decile, which nationally only 10% of the population live in. So we've got double the amount of kind of deprivation than we have than the national average. And when we're talking about deprivation, just finally, we're talking across those metrics. This is the kind of holistic view of deprivation that the IMD uses, which is what all these kind of deciles measure. At the bottom right chart. So it's income, it's employment, it's education, it's health, it's our living environment, it's our social care needs, and it's our access to good housing and utilities. Those are the things that are driving ill health and need for health. That's why we need this inequalities plan. Go on to the next slide. Sorry for rushing. And the next slide, too many interim slides. This is the approach that's slowly been growing in Barnsley, and I think it's having great success already. It's this kind of three-tier idea that across the health and care system, we can invest and introduce more services that look to specifically address the things that drive inequalities. And they're pretty simple. It's, smoking causes illness and death, and it's more prevalent in the more deprived population. So that kind of thing. Same with alcohol. It's the big risk factors. We need to do more to target, to introduce services and support mechanisms to target those things and reduce them. And we know that's important. So that's the tier one stuff on the left. The middle stuff is to say that healthcare delivery, health and social care delivery is a massive important part of putting things right. And at the minute, the more deprived you are, the less access to goods and coherent health and social care you are likely to get. And so how do we kind of reshape some of those things? So that's across all our core services, targeting them to inequalities. And then the third is what's our wider impact. So we collectively employ loads of people, have massive influence on education and employment pathways. We potentially have a massive influence on local economy because loads of the money we spend leaves the Barnsley economy, which needs supporting. And we have a massive impact on the local environment, which can be positive or negative. So that's the third tier, this kind of often wrapped up in the anchor institution stuff. And all of that is supposed to kind of encompass the health inequalities kind of action plans that we're supposed to be generating in Barnsley. And we've got a really good story about that in the hospital. We've got a really good story about that in Swift. We've got a really good story about that emerging out of PCN now and council work. And we've even started to sort of bring that idea to Barnsley 2030 board, so cross sector. So I think we're doing some really good stuff. Next slide. I'm not going to dwell on this, but that is just a few examples of the kinds of things. If you ask the organisations what they've developed as part of the kind of three-tier approach, lots and lots is happening. I'm not saying lots of good stuff wasn't happening despite it, but it also is sort of generating more energy in this space. And the plan that we're looking to develop, which is overdue and I acknowledge for various reasons, is looking about consolidating that and setting the way forward. And it's going to be a long game because we've now got the cost of living crisis that throws even more at all of this. We've got huge health and care pressures, but the long game is important. Otherwise, we're going to see, and I'll explain a bit about that. Otherwise, we're going to see that those pressures just continue and continue. So I will pause. Is there any questions on the inequalities, or are you happy for us to bring that kind of free tier of a kind of Barnsley wide plan rather than just an organisation specific plan in January?
Any questions then, as Andy said? We are planning, as you've also said, a much richer conversation, aren't we?
Yes.
I think that's the plan in January.
Yes.
Richard.
Thanks, Andy. Really interesting as always. How will we know it's working, and when will we have the first chance of measuring some improvement?
Yeah. So some of that is almost impossible. Some of that is easy, and some of that is somewhere in between. And generally, I think that's kind of, again, it's kind of across the three tiers. So we can measure how many people we are supporting to quit smoking, and that's a real good start. We can measure as we do year by year, and I'm using tobacco, which is slightly too easy an example, but we can measure how quite easily year by year what our smoking rates are doing. And we can measure kind of more process things like how well joined up we are between organisations on smoking cessation services that then feed into the wider tobacco control agenda. So that's some of the stuff we can measure quite well, and that's about kind of revisiting the outcomes and inequality framework that we might have for Barnsley. Some of it, like closing the healthcare gap, so the tier 2 stuff, is harder, but has a similar kind of approach. We already measure the difference, the kind of gradient between how many, what the deprivation gradient looks like for people who are we're using emergency care versus planned care, because we know that the more affluent you are, the more likely you are to go through the planned care system and vice versa. And so those are the kinds of things that we're now developing, especially with Helen Watson's support, some standard measurement to look at the healthcare inequalities and looking to close those, you know, to make those gaps smaller. And then finally, on the kind of anchors and the wider stuff, well, again, there are things we can measure, whether it's, you know, the amount of tonnage we waste or it's the amount of local people we employ and from which communities. But it just gets harder and harder because the work takes longer and longer. And also, if I'm honest, the impact is a very different kind of impact to clinical services. So that's as usual, Richard, I do apologise, but you'll be familiar. That's a kind of varied answer and ranging, but sort of maybe not committal enough. But I think you're absolutely right. And we are also working with South Yorkshire. Now we've got more provision from Barbara and Kieran to say, what are these measurements for the South Yorkshire and how do we bring those closer to the kind of performance metrics that they're very good at looking at to be greater accountability for all of us, including me on this stuff. So yes, we'll get better, but it'll take time.
I've got Jane next and then Julia.
Thanks, Andy.
Yeah.
So we had our first Quality and Safety Committee. So that's an integrated health and care at Barnsley Place on the 10th of November. And we've got a number of quality improvement focus areas that we've all agreed to that we want to focus on. One of those being health inequalities.
Yeah.
So I've put in the paper today, health inequalities and in brackets, areas to be worked through, because obviously it's how can we, from a quality perspective, obviously be part of and be at that table. So I just wondered how we go about doing this. As we've got our next committee meeting in January, would you be able to come and, you know, and share this work with us and then sort of have a discussion about where we go with regards to quality being at that table, obviously, with the health inequalities work?
Yeah. No, definitely. And I think, you know, I don't think Margaret Chan was quite right that what gets measured gets done, but I think measuring inequalities is something we're so bad at, apart from the high level endpoint stuff. But actually, if we bring, and Bob and I have talked about this a lot, Bob's ideas about bringing the inequalities gap measurements of the care that we deliver into quality and performance, then actually we start to address it day to day. So that's definitely what we need to do.
And we had a helpful conversation actually with Barbara Coyle and Kieran Jamie, didn't we, this morning, which we could feed back to you, Andy, as well. Julia.
Thanks, everyone. I'm so sorry I'm late, and this is probably the most important thing I was going to be doing this week, and yet I was in council and you can't walk out before the mayor. So I'm really, really sorry. And I wanted to be there as well, and I couldn't because I wanted to actually join the discussion. So, I mean, obviously Andy said what we wanted to say, and this really is about a bit of a kind of taster for the very, very important discussion we'll have in January. So my sense is that we've never had so much talk about health inequalities as we do at the moment. Everyone is really, really committed to it, but I still don't think we've got absolute clarity on how we do it, how we measure it, all of those things that we're talking about. And that's why I think a more detailed session in January is so important. But I think what Andy has set out is really helpful for us to think about, and how we get from this kind of talk, knowing it's all important, from that absolute tidal wave of rescuing and responding to the things that are really hard not to do. So I'm really looking forward to January. And again, I'm sorry I'm not there. I mean, I will be there in January, but I'm not there in the room with you now.
Yeah, thanks, Julie. I fed in really basically. The reasons why you were a little bit late. So we're going to really make sure we carve out the necessary space in that January session to have a good, really rich conversation. Councillor Platts and then Sheena.
Thank you. Apologies for being late. I'm standing in for Councillor Houghton at this meeting, and obviously the same reasons as Julia. Just on the screening, bowel screening for people with a learning disability. I sit on the cancer prevention and early detection meeting, and there were some really good results for the number of people who had with the learning disability who had done the bowel screening. So that's something that as a partnership group we're really working on, and there were some good outcomes from that. Thank you.
Yeah, I totally agree. And the other example that I wanted to put in there was the work with people with serious and enduring mental illness and the sort of the targeted health checks and other work. And that's a massive partnership approach. And you know, some of this has always been happening, and some of this has always been happening because we've always known health inequalities are there. But I think some of this is generated by the kind of discussions that we've been having for the last couple of years. So there's some really, really good examples. We are making changes, and some of it's hard to fix in the short to medium to long term locally. Some needs national direction, which we might not get. So yeah, we're getting there.
Gina?
Yeah, thanks for that, Andy and Julia. I know this is obviously something that you're working in, day out, and I think for us it's probably one of the biggest challenges that we need to tackle collectively as a partnership. So I'm glad we're paying it a lot of attention and kind of revisiting it in January as well, because although you've kind of really painted the picture and it's very stark, and it's very stark for Barnsley, I think particularly, I don't think it's fair to say that nothing's been happening in relation to this, because obviously you have been doing a lot of work, haven't you? And you've got health and wellbeing strategies, and some of the things that I'll touch on later around the development of the ICP strategy is actually focusing on just this thing around the gap between life expectancy and in particular healthy life expectancy. So I think collectively, not just in Barnsley but across South Yorkshire, it's going to be the feature of our strategic focus, really. So that's really good. But I think it'd be good to see in January what are some of the things that we are doing now that are starting to make a difference, even if it is small scale, because there's a danger that this is such a huge, wicked issue that we actually don't feel like we can tackle it, and we just push it to one side and it doesn't become part of everything we focus on. And actually, if we can start to see the small steps that we're making in relation to that progress, I think that would be really helpful for us. So if we could see some of that in January, I think that would be really useful.
Yeah, that's good. Just to, I mean, a reality. So one really positive thing, like I get emails now from hospital colleagues about, oh, we've just done this analysis of a new service and we've done it against deprivation. I've never seen that before. That's new. So that's not just the hospital. But the flip side to all of this is, of course, that whatever we do now, we are up against more challenges that are driving inequalities larger. So I think unless we're magicians, we're not going to see a close, you know, anything like the closing of the gap we might have wished for pre-pandemic. We might be, you know, optimistic to think we can slow the growing inequalities that were already happening pre-pandemic, because now we've got more things to drive it. So we need to understand that that's what we're up against. But I totally agree with everything that's been said, and I know you all support it.
Yeah, so I heard that, Sheen, in terms of the design for the January session, we'll make sure we've got time to take stock of what and impact, because that gives us hope, doesn't it? It gives us hope, I think that's really important. Yeah. And obviously signal our next steps. So it's really great. You've got some more space to go into, I think.
Are you all right? Shall I carry on?
Yes, keep going. We'll make up the time.
By my drolling voice. So we did as part of the health intelligence group now, we've obviously got the routine reporting and the dashboard that Joe spends a lot of time working on. And we tried to revive some of the kind of more bespoke intelligence that we were doing a lot of through the pandemic. We've got less capacity to do it, if I'm honest, but one of the things that we thought we'd do is have a rolling thing where we try and do a bit of a deep dive, a bit of a look at pertinent questions. And obviously this is one at the moment, which is why we so frequently reporting high levels of pressure. Today, landing in A&E, I learned, much to my surprise, that yesterday there were up to 120 patients in the department, and I've never heard anything like that in my life in Barnsley. You know, that was a busy day for hospitals 2 or 3 times the size where I was working at previously. So this is real, and it's not just about A&E pressures, don't get me wrong. This is just going through, it is high level. It's not going to give us the magic bullet, but we did promise we'd do this. So it's talking through what we did, and it's Joe Minton and Emma Robinson and Andy Eames and I doing a kind of agile look at things. So we thought we'd try and describe what hasn't changed. Things are changing all the time. So, you know, what hasn't changed, and we kind of got to the not great revelation that we need to think of things as a pre-pandemic era and the pandemic as a blip, and now we're in a post-pandemic era. So the pandemic is sort of something we can't ignore, but we need to consider, and we need to compartmentalize it. Between pre-pandemic and now, sort of acute and emergency activity in its whole hasn't changed that much. We've kind of returned to maybe just slightly above pre-pandemic levels, and that's quite a kind of, you know, I know it's said a lot, but it's quite important to think on that because of the level of pressures we keep talking about. The broad measures of things like severity of illness, which are pretty crude because obviously severity is a bit of a subjective thing, so it might change depending on how things were and how things are now, but hasn't massively changed, and that's a hospital resource group kind of measurement. Things like GP appointments and other sort of big system stuff like Opal scores have returned to pre-pandemic levels, but nothing really has changed in that space. Referrals into community care has changed to, has gone back to pre-pandemic levels, maybe slightly higher. And the outcomes from social care, I found this quite interesting, that most don't need long-term care. The proportion of outcomes hasn't really changed either. So we're back to pre-pandemic levels in many of the things that we talk about, yet we're all facing and feeling lots of pressures. So if we go on to the next slide, what has changed are some very, very real things, and the chart on the right is one of those captured. But essentially, at any one time in the emergency department, we're seeing more patients than we've ever seen. So that is, there's not more people coming in, but there's more people in the departments. That's the kind of crowding issue. And that is most evident overnight. And that's because we have this crowding issue. And then, of course, overnight supply of care, you know, your staff reduces. So it's yesterday's obviously a bit different. That was busy all day long. So like I say, things are changing all the time. But the amount of bodies in A&E at any one time has increased. The amount of very long length of stays in hospital has increased since pre-pandemic. The amount of calls to ambulance has increased. I mean, it's actually settled down a bit after a spike in 21. And with all that, of course, things either side of the system, like ambulance handover times, has increased. But there's also some really important stuff in there, like while the referrals into community care haven't increased, the caseload of in community care has kind of reached this sort of ceiling. So it looks like they're taking on people and they're needing to keep them in the system for much longer. So what's this kind of, you know, is there a severity thing there? That GPs have got this strange workload now where they've returned to pre-pandemic levels, but not pre-pandemic face-to-face levels. They're getting a lot of DNAs, and we know the various experiences that we're hearing about with GP care, and you know, and GPs are working very, very hard. And then importantly, whilst the outcomes from social care is not changed, the referrals into social care has increased massively. That's because of service expansion, but we know there hasn't been a massive expansion of capacity. So there's started to hint there that there's lots of parts of the system that are boiling, even though overall numbers haven't changed. And then if we go on to the next slide, when you look at things like mental health, we know that referrals into mental health have increased. We know through all sorts of measures that even not kind of clinical mental health, but mental health and well-being has decreased. And we know there's some real issues around that in the general population, but also in our workforce. So we've got this idea that supply side, as it were, that workforce that have got to cope with these strange increases in pressures are not as good as in a good a place as they were pre-pandemic. And we also know that it's not just about mental health and well-being where we've seen some measures deteriorate. We've also got this kind of social cohesion, this sort of social resilience falling. And so a lot of the people that would need our care but might need to get back, might be able to get back to home quickly, maybe not able to. Final slide, and then I'll leave you all in peace. No major changes in general population. There are some caveats to that, but if we go on to the next slide. So we can't explain this because, you know, suddenly our Barnsley population has wildly changed. But I mean, what has all this told us? I think that what we've seen, what we're now seeing, and this isn't just in Barnsley, is that we have returned to the norm. So pre-pandemic, the reason we were talking, you know, more than ever about population health and all of those things was because we were on an unsustainable trajectory of increasing demand on health and care services. And so people were starting to buy the idea that we needed to do much more prevention. It's not like a new idea, but it seems to be coming to the fore pre-pandemic. The pandemic was an artificial downward blip in activity because of contingency control measures. And we're now just back on that increasing trajectory of demand. But we're there with less resilience. And less resilience, general population, people have less good health and well-being, less good social resilience, less resilience in the supply side. So workforce are less resilient to it all. And those combined things are causing this kind of constant boiling pot across each part of the system that's trying to cope by itself, but doesn't have, you know, have much capacity to do so. And I think, because I'm a public health guy, that the story behind the kind of the bottom line of all of that is, whilst we work like, you know, dogs, as it were, to firefight, and we must do that, we also need to think of this as kind of some noise that we have to focus on the things we were talking about before, which is, you know, the kind of population health approach, which is inequalities, which is forcing prevention into that, but understanding there's only so much best to do. So it's the long game. It's the long game. I'll stop there.
It is the long game. It is the long game, and it's also our targeted attention in our program plan about the things that we think are going to help. So I think that's the next piece of conversation. Well, we started, it's kicked off. There's a question, Bob or Richard from Merban, about any data on the average length of stay in hospital.
It's growing. It was 4.5 days before COVID. It's about 6.5 now, Merban. That's acuity, demand. Partly, I think also we need to understand what's happened with same-day emergency care. That's expanded massively, which is what we wanted. It's really much better patient experience, better use of resource, but actually it means the caseload that's within the acute sectors, you know, they need more attention.
And there's some evidence that length of stay for certain groups has, so admissions, average age of admission has come down for certain groups in the hospital, and long length of stay age has come down as well, especially with respiratory conditions. And again, that's the kind of, so is there some severity in you know, that's all complicated. Sorry.
Can I just make some comments? First comment is, thanks Andy for coming on your lunch break and doing that. Secondly, I suppose I'm saying this more as, well, as a part of the place, but as chair of the urgent care board, this is really helpful because frontline staff know this. They know what's happening on whatever part of the system you are sort of experience this. So for me, this is starting to tell that story and give the insight, but it's like part one really. Yeah. It goes part of the way, but I think it's important that we're cited on it. I also think that we need to have this, we need to make sure we've got a universal view of it, because what I'm experiencing is quite a lot of friction between groups, which is sad. It's kind of understandable, but also quite saddening, because we kind of got to work through this together, and that is really tough in the way that Andy's kind of, you know, explained it. I mean, it's kind of really, and the last bit is just, it's really got to drive us on to do something better. This, you know, we clearly are doing a lot more to left shift, but we need to upscale it and be clear about what we're shifting, why, you know, how, who, and how we can't just sort of don't work on each other. We've kind of got to need to work together cohesively to sort of support it. And this, the ambulance bit coming in is a bit of a big piece of the jigsaw. We had the local South Yorkshire director on site yesterday, Adam, and I'm really pleased with that development as well, because it's a big piece of the jigsaw for us. It sort of brings the community feel. Do
you want to explain who Adam is?
Sorry, yeah, Adam Leyland.
You can ask me that. Yeah. I think it is.
Adam is it's a new post for Yorkshire Ambulance Service, and he's the director for South Yorkshire, and he's starting off by getting out and about and speaking. He was at Doncaster site the other day. He's meeting up with people, and it was really positive approach, really. So
I think it's a helpful investment from Yaz into the partnership post, most definitely. I've lost sense of who was first, so I don't know who was first, Marie or Richard. Does it matter? Richard.
Yeah, sorry, Marie. I don't know whether I was first or second. I mean, it's a really interesting analysis, but sort of doesn't give us nice, easy answers. And I like next time we have some nice, easy answers, Andy.
Yeah.
That we can take action on the back of. I think one of the things for me is that thinking back before the pandemic, the hospital was working at near capacity. We're at near maximum most of the time, and we could do that because we'd had such good support from Barnsley Place, particularly around discharge. So we didn't have people staying in hospital for extended periods past them being fit to go home, which meant we had a pretty lean bed base. And then more recently, we have got a little bit more delays around discharge, not a lot, but more than we used to. And I don't think we've had any slack to deal with that. And so I think it's really hard to get under the surface of it. So I guess for me also, Wendy, you sort of touched on it earlier, but the million or so pounds we're getting from the £500 million of national funding shortly, and another tranche in January. I think there's some fairly clear expectations of measurable change, isn't there, from the government on that? And I don't think we've talked about it here, but I presume we're going to use the UEC delivery board as the shared medium for working out how we use some of that money? Is that what you're thinking, Wendy?
Well, I think what we're thinking is that we'll have one plan. So irrespective of where the money's flowing, I mean, the money is predominantly flowing, isn't it, Jamie, through the BCEF routes, isn't it? So, you know, we've obviously made sure that Barnsley, the money that flows through the ICS, that Barnsley gets its fair share of that, and the methodology for apportioning that is fair and equitable too. So that we've got a combined pot of, I can't remember, the 2.5, is it? 2.5, thanks, Roxanne. We've got 2.5 million. It's travels through the BCF. There's been some recent webinars. There's some templates that have been circulated that have got the criteria, Richard, as well, embedded in them. So Jamie, particularly working with Bob, Swift, all of us together will be working through how best in the context of what we're facing, not just now, but with a look ahead to the future, how best do we deploy that resource? I think Jamie might want to come into.
Yes, so just to add, and we will involve all partners, and I've pulled a meeting together that includes everyone next week in terms of sort of sign off and approval. Our next urgent care delivery board is the 15th of December. The plans have got to be submitted on the 16th, so we've only got 2 and a bit weeks to get it in, but we've got an opportunity to go back there and just sort of sense check. But everybody will have been engaged as we pull the plans together. We've got to have those in order to secure the first lot of funding. Then there'll be some testing and challenging and want to see delivery for us to then get the January element.
There is a challenge because, surprise, surprise, it says the money has to be spent by the 31st of March 2023. I think that's what I've heard, unless I've read that wrong. Have I read that wrong?
This financial year.
This financial year. So we need to think quite creatively. That's what I'd probably say, as we always do in Barnsley, about that resource. So yeah, let's leave that there, I think. I hope that answers the question, Richard.
Yes, thank you. And I believe certainly the National Director of Finance did a briefing call the other night for acute provider, chief execs and DOFs. And what was clear is that money's recurrent, so that we can then, whatever we do choose to do with it, is going to be going forwards as well, is what he said.
That's helpful insight. Certainly not. That's not something that we've been made aware of. So that's interesting, very interesting, and helpful if that is the case. Most definitely. Thanks, Richard. Marie.
Yeah, thanks, Wendy. And sorry, Abby, I don't want to delay the meeting because obviously I'm chairing the second half and I'll end up having to talk even quicker. So, Andy, I just wonder within the report, which I thought was fantastic, by the way, whether we've even looked at the change in clinical risk of clinical practice, because one of the things we've been looking at in another trust that I'm working at the moment is people or clinical risk appetite of our clinicians is reducing to the point where algorithm management of 111, etc., is therefore by default admitting a patient to a hospital A&E department. So therefore it's taking that clinical risk away from that clinician managing somebody ordinarily in practice. So we think that could be as much as 20 to 30% increase. So I don't know whether you could have a look at that, Andy, or whether your group would be.
Over what period are you talking? Sorry, are you talking sort of pre-pandemic to now?
Before pandemic, we noticed an increase, as you said, which is, for me, it's reassuring that we're going back to pre-pandemic levels. It means people are back to normal, more or less, in terms of their clinical behaviour. But if you look at the trajectory pre-pandemic and the growth towards hospitalisation, a lot of it can be aligned to clinical or algorithm management of systems saying, if you hit all these boxes, then go to A&E or ring an ambulance. And I think, and it's something that's actually changing and increasing demand. There's a GP in Wakefield looking at it, particularly around clinical risk reduction.
Yeah, I mean, I think that's one of many examples of what Muir Gray talks about. NHS innovations have been a real driver of activity over the last, I mean, this is, going back pre-pandemic, but over the last 10 years, there's been lots of just people having really good ideas about how you reduce activity, introducing something like 111 in a kind of suboptimal way, and it generating activity for all sorts of different reasons. And you just described one of those. It's definitely a problem. And what's really, really hard about it is, how do you backpedal from it? How do you say, okay, we're going to remove that service when it's politically sensitive? But no, there's no question about that. And if I've got my A&E hat on, I've seen a few of those patients today who they don't want it. We're doing things often to people that are like, for goodness sake, but Yeah, totally agree. And how we manage that locally is crucially important, and that's working with partners like Yas and that sort of thing to see if we can turn some of the time
Thanks,
around. But it's not easy.
Thank
All
you.
right, so I'm gathering from that, we're all going to really look forward to the session in January. So yeah, no pressure, Andy. Thanks again for your working day. Cheers, thank you. All right, I'm chairing this absolutely abysmally, aren't I? So I think we have to try and gallop through because Marie, I'm landing it on you again, aren't I? Sorry, Marie. So Jane, straight up to you.
Okay, thanks, Wendy. So I'll take the paper as read. I mean, there are a couple of areas I do want to pull out for sight of the committee to provide, obviously, for noting and for assurance. But from what Wendy said earlier with regards to obviously the governance and the evolving place with quality and across system, I wanted to focus on those areas today so that we could just obviously close them off, and then from January onwards we can really be getting down to the quality business. But I wanted to first of all start off to say that although we have been focusing on the governance for quality and safety across place and the ICB, and we haven't had the formal clinical quality meetings like we had previously, that we've still maintained the quality monitoring across all NHS and provider organisations. And the areas of concern we've continued to work through with our partners and providers. So that's first of all, just wanted to put that out there. So I wanted to update on the development of Barnsley Health and Care Quality and Safety Committee, which met for the first time on the 10th of November. So the Barnsley Place Quality team had a final push to get the committee in the diary before Christmas, because the next one was in January, and we were really, really keen to get it up and running. A couple of key individuals couldn't attend, but all partner agencies were represented. The terms of reference that Kay sent out yesterday, they were the terms of reference that were agreed by the Quality and Safety Committee on the 10th of November, and they are slightly different to the terms of reference that were brought here, I think, in the meeting before last, but only slight amendments. So just wanted that to be reflected in the minutes. So due to the evolving quality governance and arrangements and a way of working obviously across place and across the ICB, and it will continue and evolve over the next 6 to 12 months, we are going to review the terms of reference in 3 months. We felt it was really important to make sure it was fit for purpose, and we wanted to make sure it was done right. So at the meeting, the committee agreed a number of quality improvement focus areas. The only addition, so they are included in the paper. So there's a list there. The discussion we had, there were so many areas that we wanted to focus on, because there's so much work that needs to be done. But we had to narrow it down to a shorter list. So they are included in the paper. But we do have an additional one that isn't included, and that's the implementation of RESPECT. So RESPECT stands for the Recommended Summary Plan for Emergency Care and Treatment. And it's a process which allows people to record their wishes about how they would like to be treated in an emergency if they may not be able to communicate. So it was discussions that we had after the Quality Committee, where it has been agreed that we will roll that out collectively across Barnsley. So that piece of work, like the other focus areas, will also feed into and report into the Quality and Safety Committee. The subgroup meetings are going into the calendar, and again, we're keen not to make an industry of this. For example, we've designed a very simple template for the subgroups to be able to report up to the Quality and Safety Committee at place, escalating any issues, any risks, but also to share good and exemplary practice. We felt that was really, really important. So the next one is about the development of the Barnsley Quality and Safety Dashboard. So the Barnsley Place Quality team have been developing this dashboard, and we discussed it at the Quality Committee, and members welcomed it, gave us some really, really good feedback, on areas how we could improve, what it looks like. And we do have now a business intelligence colleague that's going to support us to do that, because we were doing it ourselves as a Quality Committee, and we're nurses, so this isn't our bag really. So we're also mindful that the ICB is also currently developing a quality dashboard. So the Barnsley team will link in with BI colleagues across the ICB to ensure no duplication of effort. So the next bit is that we had a South Yorkshire ICB Quality Committee workshop on the 18th of November, where ICB and NHS England quality leads, chief nurses, Leslie, who's the chair of the ICB Quality Committee, Cathy Winfield, David Crichton met to work through what the governance and the escalation would look like from place to the system quality group and to the ICB Quality Performance Engagement and Experience Committee, also known as QIPE. So we had some fantastic discussions at that workshop, and we really worked through a lot of the different questions and, you know, the clarity that we required. One of the outputs was the development of an escalation framework. You know, what would we escalate and when would we escalate? And Cathy's currently writing the outputs of the meeting with her team, and I will obviously share that once I get that. But Leslie, you wanted to add a few place, don't you think?
Probably said it all really, Jane, in a way. I just think my reflections from that quality workshop and also in terms of work happening at places, obviously things didn't stop. You know, as Jane said, things still needed to continue to happen while the new organisation, new structures were established. And it's been really important to see that those things have continued. I think that's great. I think the second thing from my point of view was that what we didn't do was put loads of additional pressure on people to report things, but that it was done appropriately. So, and I think we're still working through what's appropriate to report at place, what's appropriate to report at system level, where are we providing assurance. Each place committee has got a non-exec on here. So one of the things is, for me, is about the role of the non-exec in assuring quality at place and reporting back, so that, you know, there's a conversation to be had about that. And as Jane said, then there's also that need to get that escalation system in place, so that things are done consistently across the piece. And then just final thing for me is just to say thank you to Jane amongst everybody else, because it was a really good workshop. I think a lot of things were bottom, real energy in the room, lots of key things that came out of there, and a plan now in place to actually start to bottom out some of the things that were causing a bit of stress for people about, you know, in the new system. So overall, I think it was a good morning, wasn't it?
It was very good.
Time well spent, and work's not finished though.
No.
I'm just looking at the list of 8. I haven't got my glasses on. 8 action areas that were captured from that morning, and so what we agreed was that we would do another similar event in 3 months' time to look at where we were with some of those things and report back again.
Yeah, so I guess we're still in design mode, aren't we? Still very much in design mode, and value add, so that when we do bring people together, I guess that it's making a difference on quality. We're not cross-cutting over what a primary organisation's response is to quality, but actually we are harvesting our intelligence around some of the common themes, and we galvanising our collective efforts to make a difference.
Sorry, and I think on that, I think then what we didn't really get into too much, but we started to mention it with Jane, that actually some of the issues we might have about quality might actually be better able to be addressed at system level. So it's about understanding, you know, where is the best place to get the best outcome on those things.
Exactly. Jane, one final thing. Have you got anything else?
Yeah, it's warm, isn't it?
It is warm.
So yeah, just one final thing. I thought it was really important to bring to here to share with the committee what we're doing with regards to, you know, the Panorama programme on Eden Field Hospital that you should obviously share. I'm sure most colleagues have seen that. So just wanted to share what Barnsley are doing to seek a greater level of assurance and the safety and quality of care of people with mental health, learning disabilities and autism who are living in out of area placements. So we have, I think, probably 30 people placing hospitals and specialist placements out of area. And we're also, Barnsley is also the host commissioner for Signet Oaks, which is a 35-bedded hospital for men with mental health, learning disabilities and autism. So we have drafted a letter which will be going out to all host commissioners of out of area placements, obviously to Signet Oaks and placing commissioners, seeking information and assurance. And we want to know about any routine quality monitoring undertaken, any concerns they have, and the steps being taken. And this is really important to mitigate the risk of closed cultures. And I think that's really important. How best can we share information, and how can the ICB be of support to those commissioners and providers? So we've nearly finished getting all the information on all the out of area placements. It hasn't been an easy exercise. We knew who all the people were, but because we've had the change from the clinical commissioning groups to ICBs, it's then who obviously do you link in with and so on. So it hasn't been a very easy exercise, but something that had to be done. So the letters, Wendy, for you to sign that off, and then they can be sent out. And with regards to Signet Oaks, which is obviously the Barnsley hosted placement, the head of quality and safety for Barnsley Place met with the head of care at Signet Oaks to discuss what assurances needed to be sought from that provider. And obviously we'll continue to do that going forward, because we have obviously not just Barnsley people placed in Signet Oaks, we are also the host commissioner for other commissioners who obviously place out of area. So I just wanted to put that on the committee's radar. So the committee is asked to note the progress, Chair, with the establishing quality governance at the ICB and place, and updates with regards to quality in the safety work area.
Okay, thanks, Jane. And
Wendy, can I just ask a question on that?
Oh, sorry, there's some questions. Sorry, yeah. Jane first. I'm blind again. Jane and Sheena, then Richard.
Lovely. I just wanted to mention about the role of advocacy in this, because we have our independent mental health advocates, and you'll probably find within most of the private hospitals that they have their own advocacy services, and it's difficult for them in terms of feeding up, because the place that they'll be feeding up to usually will be the provider. And if you've got a closed culture and they feel unable to raise those things, so I think generally we should have advocacy involved in a number of meetings, so that those issues, those trends that are coming out can get fed up. Thank you.
Very helpful, Jane. It's a really good point, actually, isn't it? Yeah, we'll have to think about the approach to that. Actually, it's a good point. Sheena and then Richard.
Yeah, thanks for that. And it's good to hear that we're sort of adopting those principles around measure once, and kind of being clear about where some of those statutory responsibilities lie. And obviously we're still sort of designing this, as you say, and kind of tweaking it as we go. But I just wanted to understand, so because the report sort of describes the process for us, and then it says that it's for noting, consideration and approval. So I just wanted to understand, what is it that we're actually approving, and at what point will we start to sort of have that oversight as either committee or as the board? And that's part of my question, is I'm not sure what sits where when. When will we start to sort of see that sort of oversight around those quality measures that we want to pay attention to? And when we talk about escalation, are we talking about escalation to the board of the ICB, or are we talking about escalation here as a place? I'm not quite sure which we're referring to, and I just want to understand what's our role here, because clearly there's a network of kind of committees and colleagues that are contributing into the whole picture, but at what point do we get involved, and where's our role in that, I guess?
Yep, thanks, Sheena. Jane.
Okay, thanks, Sheena. So obviously the 10th of November meeting was the first one that we'd had. So it was very much about getting the governance right and, signing off terms of reference and agreeing, focus areas and so on. but the subgroup meetings are going in the calendar. So those are those that are included. Obviously, I think it's in the paper, but certainly included in the terms of reference. So they are going in the calendar. It will be for those subgroups who will then be escalating any of the risks or issues into the Policy and Safety Committee. For us then at the committee to try and resolve if we can, and if we can't, if it's something that needs to be escalated further, then that would come here. For the partnership and the place to obviously be able to then to try and resolve if there's a wicked issue that we need support with, that would come here. So we've got a couple of meetings for the subgroups going in before Christmas. So I would say for the January partnership board, there may or may not be anything that may be escalated here, but there will be obviously an update of what potentially we have discussed at the Quality and Safety Committee. But I would think that going to March and May, that's where it'll start to build momentum. We should have a better dashboard at that meeting. It's just taking time to develop these in place. And what obviously Leslie mentioned earlier, we're still working through what gets reported here, what gets reported. Is it something that has to go straight to the ICB? Is it something that needs to be discussed at the system quality group? So again, we're still working through those. It's really complicated, and it's taken us all a lot of effort and time to get our heads around what this new world looks like. But I'm really hopeful that sort of March onwards we will start to see more clarity and a more clearer way forward, if I'm honest.
Is that helpful, Sheena?
Yeah, and I accept it's a work in progress, and we're still developing as we go. So I think as long as we adhere to those principles, as you say, and not kind of trying to minimise it and looking at our added value, I think if we keep that at our heart, I'm sure we'll get where we need to get to.
I'll check the rest of the questions, then we'll come back. I'll check the rest of the questions, and then Jane can come back at the end. So Richard.
Thank you, Jane. I appreciate this is a difficult area and you sort of working out as we go along, but I've got quite a few concerns about this, I guess, and partly because I don't understand it. So I guess as a principle, we need to keep it as simple as we can. And my reading this paper suggests there's an awful lot of committees going in. So there's something called the Barnsley Hospital, blah, 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 Quality Improvement Group. I don't know whether that's an existing group or a new group. I'm reluctant to sign off new groups because my team are working very hard already. I don't want, I really don't think this new ICB place structure should be unnecessarily bureaucratic. I also want to know the difference between quality assurance and quality improvement in terms of what we're doing here, because I think there needs to be some sort of oversight in what we're doing from a quality point of view, but that's different from quality improvement. I think quality improvement is what we do internally to improve things. I presume that the place and the ICB will want to have some sort of quality, some sort of scrutiny of the quality of the services we're providing, and that feels like it needs a different mindset and different set of skills. There is little information on here what the quality team will look like, and I'd be really interested to know that. I haven't seen the terms of reference. I think you mentioned they've been changed, but I don't think we've seen what the changed ones look like. And there's things like, for example, things that we worry about, like the Acorn unit and the complicated arrangements around that, which I think needs addressing. So what was in my head is I thought Barnsley would have potential a risk register that would flag the things we're concerned about in Barnsley, which would then drive some of the quality work we collectively do to address those risks there. So, and the last point, there's a lot of focus areas. So again, it's about the bandwidth to sort of deliver that, and whether or not there needs to be a smaller, tighter number of things that we need to focus on collectively, and therefore have some chance of really making a measurable difference. So really strongly supportive of the sort of, intent behind this. I'm a bit anxious that it feels a little like it needs some more thought, and I don't know how much each of the partners has been engaged in this. I'm sure they have, but I don't know that. So I don't know whether my colleagues back at the hospital are fully behind this or not.
Okay, that's really helpful. Thank you. Marie?
Yes, thank you. And again, I don't want to appear negative. I'm echoing a little bit what Richard said. And it's only because I got my hackles up a little bit when I heard about, you know, the problems we've been having in the mental health trust in Manchester, and then more letters coming out seeking assurance. We are absolutely assured to death. We've been bombarded with letters from ICSs, ICBs about giving them assurance, and I just need to make sure Place isn't repeating what our ICS in South Yorkshire's already asked us for anyway. So that would be helpful for that one. The second one, I'm a bit like Richard, and again, forgive me, I'm only a chair, I'm not involved operationally. I think there's a massive difference between assurance and not just quality improvement, but quality delivery. Because at the end of the day, I'm sure as a committee, you wouldn't want to take responsibility for clinical risk delivered by an organisation. And I think that's something we need to think very carefully through as a quality committee. But I'm sure my staff in Swift are involved. If they are, that's great. Forgive me if they are. And I don't want to be a P negative, but I do think we need to be a little bit careful around what kind of risks the committee hold and why they hold them, where the risk sits and how it's assured. So I'm not being negative. I just think it's, as providers, it makes us quite nervous, I would say, from my perspective.
That's helpful, equally, thanks. Jenny?
Yeah, that would, Marie sort of asked a lot of the question I was going to ask, because, you know, just thinking about when there were Winterbourne View, and you know, we checked everybody that was out of area, and you know, we didn't have any Barnsley people in there, but you know, I think it's really important that we make sure that everybody is assessed and monitored, that we've got out of area placements, whether it's, you know, with the advocacy that Jane's talked about, but we really need to be assured that those people are safe.
Thanks, Jenny. Do you want to come back, Jane?
Yeah, thanks, Wendy. Thanks for the feedback. It's really helpful. So the easy one is the terms of reference was circulated yesterday from Kay, but I'm happy to send it to you again, Richard, after this meeting. So wider partners, everybody's been involved with the development of this. So we had a number of workshops even before we moved from the CCG to the ICB with most partners, certainly from Swift and BH&FT, and they've been involved with the terms of reference. So Daryl from Swift, and obviously Jackie, Simon, and other colleagues. So they have been at the table with regards to this. The subgroups, so there are no new groups in this apart from obviously the primary care, which we're looking at with Jamie, because there is a primary care quality improvement group that's with the CCG. So we're just looking about what that looks like going forward. So what we've done is, because we used to have a quality and patient safety committee, and then we had clinical quality boards underneath. So for BH&FT and Swift, that would be there'd be Jackie and Simon that would attend for BH&FT, and there'd be Daryl, and I think it would be Jill now, but Jill that would attend with colleagues the clinical quality boards. So what we've done is that Jackie, Daryl and Simon, for example, will sit on the quality at place committee, and then it will be the team that would have come along with Jackie and Simon and Daryl to those meetings that will form the subgroup. So we've not replaced, we've just changed where we do a lot of the discussions. So a lot of the discussions for quality and safety will be done by Jill Feely, for example, for BH&FT. The quality committee at place, so it's a new one, and actually we're the first across South Yorkshire to have an integrated health and care. So again, that causes its own complexities, that we're trying to get quality and safety at place across health and care all around the same table. So going back to the point with regards to, you know, it's not to repeat what goes on in the hospital, but it's about quality improvement. It definitely is about improvement, but at place, and what we can collectively do as partners together, rather than doing it in separate organisations. Risk register, we do need to give some thought, and that is something that's been on my mind, and that I was going to pick up with SMT. And yeah, the focus areas, when we were talking earlier, and I was saying, you know, that we had a list of so many and we brought it down to less. I think that does need further thought.
So it's helpful conversation actually, really, as we build this sort of approach together, really. And Sheena's right, really, absolutely completely focused on value add all the time, really. And we're conscious of the resources that we've all got. They're a finite set of resources, so we do need to make sure. Bob, do you want to say anything at all? Because I know your team's been involved in this.
The Quality Safety Committee. Yeah, they've seen the terms of reference and I've been told they're happy with it. But yeah.
All right, thanks then, guys. And we note the risk register. Further work for us to do on that. Okay, majorly behind time, so I'm over to you, Jamie, for the next item.
Yeah, no problem. I'm not sure I can take us back in time, but I'll be quick as I can. I just want to, because this is about mental health, LD and autism, which we've flagged already, haven't we, today? That's really important. But one of the things I just wanted to reflect back to Jane and the conversation, not you, Jane, that we're presenting this morning, and just recognise how enthusiastic and committed our teams are. So the way that she presented that showed that real enthusiasm, didn't it, to make things better. And we see it in mental health, but we see it everywhere else. So I'd wait and do it now when we're doing this paper. It is intended just as an update. Pick out 4 key areas. One of those Jane's just touched on because it was discussed at the quality group, which were around the Eden field work and the assurance there. So I'll not pick that section up. If you want to read both, you'll note we've not been duplicating. I've been copying. So it's the same information. We're both telling the same story, but it were there just in one place. So the first that I wanted to touch on was just around the mental health LDA partnership, so Learning Disability and Autism Partnership. In Barnsley, we've had a number of groups that have been meeting for a while. One of those being the Mental Health Partnership, one being the Learning Disabilities Strategic Group, which focus on adults, a Special Educational Needs and Disabilities Oversight Group, and a more recently established Autism Partnership. But I think recognising the collaborative at system level and the arrangements that happen across, it was agreed that to make this an integral part of our work and the place partnership and give it the focus that it needed, we would establish a mental health, learning disability and autism partnership, bringing all of that together. It's a mouthful, that, isn't it? So the rules set out there, I'll not go through in detail, but is around agreeing the vision for those 3 areas. It's easier. Development and progression of plans, managing and mitigating risk, and making sure we're meeting statutory regulatory requirements, and then providing system leadership around the health and well-being of those people affected by the 3 areas. We've referenced already that 31st of October, there was the launch event, and I've picked out a couple of areas there around creating that joint understanding of key priorities, and the session that Ed discussed on the 19th of December, which is the first meeting really, we'll take that further. And I guess just because you sat at the side of me, Adrian, I'll pick out that it was agreed that to reflect what we had for the mental health partnership, it would be appropriate to continue to have an independent chair of that partnership, and Adrian will be taking on that role. So we'll keep that good work going forward. The other members are also listed there. I think that's the key bits on that. I also wanted to provide a bit of an update in terms of the all age autism strategy. So people that have been involved know this has been coming a while. There have been various reasons that it's taken some time, but if we recognise in here that the first national strategy, all age strategy for improving the lives of autistic people, only were published in July 2021. We've not previously had an autism strategy, so there's been agreement that we would develop that. We'll reflect in that the 6 areas of the national strategy, which are the bullet points included, so I'll not read back through them. The first draft, it is expected by the end of November. My understanding is that's now there and ready. That's been developed taking account of existing feedback from services, from service users, their families and carers, but from information that we already knew to get to that stage. So I think we probably have to accept that it's maybe not a fully co-produced strategy at this point, but there's now a period of engagement to get there, and I think a commitment then from what was the Autism Partnership and what will be the MHLDA Partnership over the next sort of in 6 months to begin to review that and make sure that it is right for Barnsley people, that we wanted to get something in place. So that should be there to be approved through the partnership in January. The next section I'll not touch on because that's what Jane has covered, and provide that assurance. And then the final were linked to that, and recognising Jane's picked up through the quality group that mental health and LDA is really important, but recognising some of the points that have been picked up in the conversation, we felt that rather than just wrapping up some of the mental health LDA stuff within a quality report, it would be appropriate to bring a report here 6 monthly, specifically focused on some of those issues in relation to mental health, learning disabilities and autism. So what's included in that section is our sort of structure for what we think we would need to bring to give that assurance, the key headings, and we'd be looking to do that in January, so it would come to the first meeting next year. And I guess from a recommendations perspective, I'm just asking members of the committee to note the contents of the report, to approve and agree that proposal that we bring a 6 monthly assurance report in here, and then to consider the proposed content that are in them bullet points of the assurance report. And if there are any additional areas that committee members feel that we should include, then either raise them now or send them through to either me or Jane separately, and we can make sure that they're built in. That's it. Thank you. Thanks.
Very helpful to see that. Any questions at all? Pretty straightforward. Okay, thank you. Just check in, make sure I haven't missed anybody. All right, thank you. Let's see what we've got next. So I think we've got, you've got a summary read of the Barnsley Place Joint ICB and Adult Social Care Senior Management Team composition, which you asked for. It's there for information. We'll keep that up to date and share accordingly. Can't imagine there's any questions on that because it's pretty straightforward. Oh, there is a question, Dave.
Wendy, sorry, Wendy, because I know you're trying to get through this quick, and it might be just me. You know, it might just be me because it's the first time I've seen it sort of presented in this way. It was just that, I mean, I've heard obviously described the kind of put your sort of service, your portfolio before, but I kind of understood that for you to be wearing two quite distinct hats in a sense, and part of the role being about the challenge and opportunities that come with wearing two hats at the same time. Whereas this clearly describes it as far more of an integrated portfolio with a very much a joint kind of leadership and management structure, by which I assume the team meets together, ultimately will share the same values, priorities, certain strategies, etc. Insofar as that cuts across commissioning responsibilities, I suppose I kind of get it. I don't know what that means for the council as a provider, because clearly there's a significant provider element to that. And I don't know what that means for the relationship between the ICB and commissioning more generally, and the council as a provider, as against the relationship between the ICB and commissioner and other providers in local system. And like I say, it's the first time I've seen it, so I'm kind of getting my head around that, but there seems to be some challenge in that. Really.
No, that's very helpful. I guess I've got to manage that. I've got to manage that in terms of sort of declarations of interest, both within the ICB and I guess at place as well, really, because again, as you said, quite right, you pointed out, Dave, that's it could be a challenge, but declared the interest. I've almost like declared my interest as being a DAS on that conflict of interest in the declarations of interest, really, and that's been really quite clean and quite transparent. I think the approach to commissioning per se is one thing that we have to debate and consider both within the ICB and at place. I probably can't say much more than that right now, but it's something that we know we need to explore.
Yeah, so just sorry quickly, Wendy, because I understood that in terms of your declaration of interest. I guess if everyone's part of the same integrated management arrangement, then everyone's got that. Everyone's wrestling with that potential interest and conflict, and not just yourself, which I understood was an issue for your role. But anyway, I'll leave it at that.
Yeah, there are. I mean, it's a good point actually. There are terms of reference. We've got to build terms of reference, haven't we, for the health and care joint leadership team. It does meet jointly, as you asked it. We do meet jointly, yeah, there are terms of reference for that. And I guess we'll have to think, Richard, about any form of declarations of interest, probably more systematically, maybe in that meeting. So helpful feedback, Dave. Thank you for that. Okay, let's move on. You've got also in your pack. I'm conscious of time, and we have tabled the get my right item actually on. Oh yes, sorry, it's the forward plan, isn't it? I'm jumping ahead to Marie's agenda. Jeremy, forward plan.
I can keep this brief. So there's a paper. Yeah. The draft forward plan at the moment. I'm sure it will evolve over time as we consider more items or realise we missed things off. It's the draft at the moment, so bring it to you today just for you to look at and for your approval at this stage. Thank you.
Thank you, Jeremy. Any questions on the forward plan? We've already talked about, obviously, the health inequalities element for the January meeting. There is a proposal to stand down the development session on the 15th of December. Unless there's any burning items for that meeting. No. So, yeah, just to note that we're okay to stand that down. All right, let's move on. Roxana.
I'll keep this very brief unless anybody wants questions, because I think the report sets out the position in terms of the delegated budget for Barnsley from the ICB. It just sets out the financial position, where we are in terms of the forecast, currently assuming a break-even position against the budget of 543 million, with some emerging risks around prescribing and continuing care and complex cases. I suppose the thing for the partnership to know more broadly is that actually we've had our first finance performance and efficiency group meeting with all the directors of finance, and we have started thinking about how we will report into this meeting from January. So that's probably the key thing for this committee to know actually, but the report is here that just sets out what the ICB financial position for Barnsley looks like at the moment. So I'll take any questions and keep it as brief as that.
Thanks, Roxana. Any questions on that item? Nope. Okay. Let's move on then, and we've got some senior management team decisions as we bring them in here. We've got a couple there to note, really. Some development on the Worsborough lift building to enable that space to have better utilisation of the space fundamentally, isn't it? So that's one item. And then interesting, the UEC one, which was Jamie, do you want to talk about that very briefly?
Yep, no problem. We've talked about it through the urgent care board, but this was some funding that were provided nationally to look at how we can improve or test out different ways of clinical assessment, ease some of the pressures on ambulance services, and we agreed in Barnsley that one of the ways that we could try to do that would be to take some of the calls from what they call the stack, so the pile of calls or whatever we want to call it in Yaz that were waiting for category 3 responses, and link them in with our Right Care Barnsley service to see whether, rather than waiting for an ambulance, the Right Care service could support, direct them to alternative community response, including our urgent community response. We're ready to go with that in terms of the training now. What we wanted to use the funding for was to make sure that the teams that would be involved get some training from each other. So some of the ambulance staff will do overtime, come in and work within Right Care Barnsley to understand what's going on, and likewise the other way. I think just for assurance, if people are thinking if somebody's passed over to Right Care Barnsley from the ambulance stack and they can't deal with it, what happens then? There's a pathway back in, so Right Care would pass the patient back. They would join the queue in the same place that they left it. So it wouldn't mean that they're back at the bottom and the waits increase. But it does mean that if they can be dealt with through an alternate route rather than an ambulance being dispatched, then they would do that.
It's helpful. Any questions on that at all? Not, I think that's it. I have caught up a little bit of time there. So I think we can call that part of the meeting to an end. And I'm going to pass over to Marie.
Yeah, thank you very much indeed, Wendy, and apologise to colleagues for not being there. That's completely mine and my secretary's fault. Otherwise, I'd have been in the room with you. So I'll share it on Teams. Anybody sat in the boardroom, if you can wave at the screen and say your name, I'll bring you in if you have a question, if that's okay. Other than that, I'll treat it like a Teams meeting from my perspective. So thank you very much, everybody. I'm going to move on to the first item, which is update from South Yorkshire Integrated Care Partnership, who Sheena is our representative. So Sheena, I'm going to hand over for you for an update, please.
Okay, thanks, Marie. I'll keep it relatively brief. So the engagement packs in the papers that we've all seen as well, and they've been circulated to all of the providers across Barnsley Place as well as across South Yorkshire. And they did a bit of a kind of a name and shame of who's been sharing, and it's fair to say Barnsley featured pretty well in terms of the sharing. So I think that message is getting out there in terms of engagement. So so that was really positive. And obviously, as Wendy mentioned right at the very beginning, this is on top of the review of what was the existing engagement piece that had already taken place. So hopefully it'll be a fairly comprehensive feed into the strategy. So at ICP, at the Integrated Care Partnership, we've got a clear task, which is to develop the strategy in a really short space of time. So we've had a small working group kind of delivering some ideas and suggestions to that. And we've got a development session on Monday where we're going to be discussing what that looks like, and we've got a draft strategy now which has just arrived in the inbox as we've been chatting today, and we've been invited to vote on a couple of visions for that strategy. Bearing in mind this is an overview of what we're going to do across South Yorkshire, so it's building on what's already in individual places health and wellbeing strategy, so it's not anything that's kind of will be a surprise to people. But I think what we've sort of been discussing that our focus needs to be is around the things that Andy touched on earlier, which is around life expectancy and closing the gap, but particularly around healthy life expectancy. And there's an acknowledgement that our sort of influence on that will take some time to demonstrate, but that's where our focus needs to be. We're also looking externally at what others are doing, so particularly in Wales, Scotland and New Zealand around their approach and seeing how we can bring that into our strategy. But our strategy is really going to focus on prevention and early identification, on health and care workforce, inclusive and sustainable economy, and then quality improvement. So those are the kinds of things. So again, I don't think there'll be anything that'll be a surprise to people when the strategy is agreed, but it is a kind of overarching view of our ambition really, rather than some practicalities around what we're going to do, because I think some of that still needs to be worked out, and the timescale that we've had to deliver this has been really, really tight. So we've got a further session, as I said, on Monday, and then a final just before Christmas sort of sign off, I guess, of the strategy. So I'll happily circulate the draft strategy to colleagues if you think it'd be useful and you want to add anything to it. But I think it's going to be a build on what we already have in place, and as I say, kind of really kind of focusing on ambition rather than delivery plans at this stage. So yeah, happy to take any questions.
Thank you, Sheila. Yeah, Julie Burrows, please.
Thanks, Sheena. And I do think that we definitely have the A team from Barnsley into the ICP. We've got a really good mix. And I completely agree about the strategy that and Sheena, you said no surprises, and in a way it would be really refreshing if there was a surprise, wouldn't it? Because it's going to be really inclusive. It's going to say all the right things that we all agree with, but it kind of means that we're not going to be really focused on one or two things. So and I kind of get why it's going to be our health and wellbeing strategy is like that, but in some ways it would be more effective if there was just one thing we were going to do, wouldn't it? And I know everyone said that, but that's my reflection.
Yeah, and I think it's a fair challenge really, and I think that's what we're all grappling with really is, people are working hard individually and collectively at place, but what extra are we going to actually deliver as part of an integrated partnership across the whole of South Yorkshire, and where can we have the investment to make a difference there? And I think, to be fair, the strategy is not going to set that out. It's really just what are our ambitions, because we haven't really had time to think about, well, what does that look like? But I think one of the things that we did sort of try and narrow it down to, so, closing the gap is a big challenge, and particularly for South Yorkshire, particularly for Barnsley, I think. So when you see the evidence, and we saw some of that earlier in your presentation, it's huge. But actually, where you see the bigger gap is around healthy life expectancy, and I think that's where I think we want to have a focus. So it's not just about extending people's lives, but actually extending people's quality lives, because that's where we perhaps can have more impact. So I think that's where our focus will likely be.
Thank you for that, Gina. Thank you for that, Julia. Any other comments for Sheena? Do you want to come in, Jeremy, or anything? Because now this is yours as well.
You've got to shout your name as well.
Oh dear.
Andy's waving.
Can you hear me? I'm waving my arms frantically.
I can't see you at all. So
Oh,
you're going to
dear.
have to
And I've got
put your
quite a
arm in the
loud
middle of
voice. I've got
Okay,
quite a
go
loud
for it.
voice as well. Oh
Go
yeah,
on,
okay.
Wendy.
Well, yeah, it's all right. So thanks, Sheena. I think it's investing in the youth of society. I think it's got to be so important, hasn't it, really? And that we get behind things like school readiness we know across South Yorkshire there are real issues on that, really, about helping people. But it's not just about school readiness, even just in terms of school readiness, that has such an association, hasn't it, with good housing, efficacy of strategies for domestic violence. I'm not saying that's appearing in everybody's house, but all of those associated sort of necessary areas of life that I think we just need to pay attention to. And surely I'm hoping that something around economic inactivity and worklessness and the workforce quandaries that we see across health and care, that we hope that some things around that would emerge, because that therein lies one of the benefits of having the mayor, I guess, really in there, is about how do you stitch some of this stuff together. But it's tricky stuff, isn't it, about what happens, what pieces of that change puzzle happen at what place. So it's put some really helpful conversations, Sheen, I think, haven't there? And there is the Bloomsburg, can't remember what they call it now, Bloomsburg philanthropies, is it?
Harvard Bloomberg.
Harvard Bloomberg, yes.
Yeah, I've not mentioned that, actually. I was going to come to that next, actually. I realised I'd not said anything about that. So should I do that now?
Yeah, go ahead, Sheena. Yeah, talk about Harvard. Go on, Bloomberg.
Well, obviously I'm an expert in Harvard, but Harvard and Bloomberg, I can't say I know a great deal about it, to be fair, but there was a launch session which I didn't attend. I think probably other colleagues from Barnsley did. That was on the 21st of November, which was a kick-off session, and I think it's really around and again the focus there was particularly around children and young people, and I think those messages that you talked about, Wendy, around this good start in life kind of approach really was really key to some of our conversations in relation to that. I think the Harvard Bloomberg thing is something that Oliver Coppard's been involved in across different countries as well, around their approach to some similar challenges, really. And I think we're hoping that, to that point that Julia spoke about, around something unusual, different, transformational, more of a surprise might come from some of that relationship with Harvard and Bloomberg. So I don't know exactly what that's going to look like, but I think it sounds like an interesting proposition, and obviously we're engaged in that, because I think Oliver is keen for us to sort of build on that work, and so I think it's just a case of watch that space on this, and we'll feedback anything more. Kathy may have something further to add, because I think she was probably involved. And thank you for your comments about the A team being from Barnsley, but of course we do have Richard as well from Rotherham, so I wouldn't want to exclude him from being part of that.
You can be A-, Richard.
I can be in the B team. I'm okay with that.
Okay, in the middle there, waving at me. I can't see faces hardly. Go on.
It's Adrian, isn't he?
Adrian, go ahead, Adrian. Thank you.
Thank you. I was actually at the launch on Monday, and it's going to be around health inequalities because that is the widest programme that the South Yorkshire could get involved with. So look at the wider determinants of health going forward. So that should be quite interesting. It'll be very hard work for 8 people. That's all I'll say. They're selecting 8 people. One of them's already been picked. Work programme is for 3 months, including some time in New York. But I think it's going to be rather like going back and doing a PhD. Very, very hard work.
Okay, thank you for that. Yeah,
Don't think many people will be volunteering for it.
I did work with Bloomberg Philanthropies when we did our Love Where You Live campaign and all that sort of. They were quite involved in that with Nesta actually, and they were quite. I'm quite hopeful, Sheena, that they do bring some of that creativity and cut through some of the twaddle, excuse my French, but cut through some of that and think about something really creative, dynamic that we can do. As Julie said, even if it's just one thing that we can really think about doing differently.
The one thing that came out of it was working at neighbourhood level.
Again.
Okay. Absolutely, yeah.
Julia, do you want to come back in, Julie Burrows?
Very, very quickly, just to suggest a good book for everyone to read, Saving Gotham, which is about the Mayor Bloomberg tenure as New York City Mayor, where they did some huge public health things. So it's a real public health textbook.
Oh, well, thank you for that, Julia. Okay, so we'll look forward to that, then, Sheena, and that developing and putting Barnsley on the map for Bloomberg. Okay, thank you very much indeed for that. Anything else on that particular item? Anybody want to wave at me? Yeah, I've got a waiver in the corner.
I am waving.
I've got you.
I just wanted to, it's not so much about the strategy, I just wanted to make the point that although we've got Barnsley's A team in there, there's not a lot of representation at all on the integrated care partnership from the voluntary sector, because I'm being told to talk to our reps and I'm finding it quite difficult because I think it's more rep than reps that are on there. So I think we need to look at that.
Okay, let's pick that up then outside. Can we do that, Wendy or Jeremy?
Yes, yeah. Let's have a conversation about how that works. It's also about how that sort of circular communication works. So the people who are representing Barnsley in those conversations, how we touch base with you guys as well and feedback, the feedback loop. So I think there's something probably practical maybe we need to do as well, Jane. But yeah, we could do that.
Thank you, Jane, for that. Okay, I'm going to move on then, if I may, to Barnsley Place Plan and Target Operating Model. Jeremy, please.
Thank you. So I will be keeping this fairly short, I think, because we had a good conversation at the development session in October. So the slide deck that's attached here, I'm not going to go through that again. We went through it in detail in our last meeting. We've heard from Sheena as well. Thank you, Sheena. Updated on our ICP strategy. And of course, as we take forward our Barnsley plan and think about that for 23-24, we'll just make sure it's orienting both to the principles to be set out in the target operating model in the slides that are attached, and of course the integrated care strategy as well. And we'll then be creating the joint forward plan for the ICB, both across South Yorkshire and at Place as well. Just worth noting that there is already some public and staff engagement being undertaken to support the integrated care strategy. So it's been a really good piece of work putting together 284 reports from ICB partners. We're still waiting to see the detail of that, but that's a really good piece of synthesis, bringing that together, making sure that all the lessons that we've been hearing are being pulled into one place for us. There's a phase 2 underway at the moment with one simple question: what matters to you about your health and well-being? And responses can be submitted online to that or via email until the 11th of December. And then there's going to be a phase 3 as well, where there'll be a chance to submit people's views on that high-level initial draft, which I think you've seen today, Sheena, and that will be published online imminently. So moving on from that, we took the work that we did at the development session in October, and we now have our Place Partnership Delivery Group meeting meets every week, but it also now meets on a monthly basis as well. 2.5 hours monthly, just to really focus on its delivery. That's what it says in the title of the group. But we have to start by understanding and getting clarity around what we think the priorities are that we want to deliver as a partnership in 23, 24 and beyond. And that's a crucial distinction. I've made it before. We all have organisational plans which we have to work to, lots of must-dos. But around this table, it's about what else can we do? What's the value add of this group, this partnership, to deliver for the people of Barnsley? So we had a really good session 2 weeks back now. Time flies. Where we asked colleagues to come prepared, and they did, to help us to think through what they thought their top 3 priorities might be, focusing those on the best outcomes for residents, what the impact with staff would be, and what the impact on flow and efficiency would be as well. Lots of good work on that. We're just working our way through that at the moment. Back to the delivery group once already to carry forward those discussions, and we'll be doing that again next week, and we'll be coming back to this group in the new year. I think a report back in January would be appropriate, just to update you on progress there. I'm conscious I'm one of many around the table, so I don't know whether other colleagues want to sort of chip in on that sort of ongoing work.
Any comments, colleagues? Yeah.
To add, I guess. So Jeremy referenced we started to do that work, and we've had a conversation through the delivery group. What are the sort of 3 most important things for us all, and tried to collate that together. I think we've just got to be mindful of, we want to get our plan in place. We don't want to rush ahead too quickly, having heard what Andy's been saying earlier and what we're going to be talking about in January, because we need to make sure that our plan is addressing what that is telling us. So what the health inequalities data is telling us, what other intelligence is telling us, to understand, I guess, what are the problems or the challenges that we're trying to address, what impact are we trying to have, and then what are the individual things that we will do to make that difference. So I think that's what we're trying to work through now with the delivery group, to make sure that we've not got a million things that we're trying to do as priorities, but actually recognise that there will still be quite a lot of things that either together with our partners or individually within the hospital or within children's services or within mental health will be taking forward that contribute to that. So I just wanted to guess, make that point that we are trying to just bring all of that together, and also recognise that we need to respond from place to what the ICP strategy says as well, don't we? Which we're only just seeing.
Yeah, Wendy. Yeah, I've got your hand up, Wendy.
Yeah, so I mean, given that, if you go back to the forward plan, given that we said we're going to have a rich conversation in January about health inequalities, we should see the ICP, shouldn't we? Integrated care, strategy emerging, shouldn't we, by December, February? Yeah. We've got a development session in February. That might be the good time to have a really good look around, actually, then in the context of all of that, what's our place plan? And we have a really good session. We will bring forward a proposition around that place plan in terms of the impacts and all the rest of it on there. And then we work on that together live at that development session.
That would make sense. Yeah, that would make sense. Okay, are people happy with that proposal then? Yeah. I can't see anybody. Okay, thank you very much. Thank you for that, Jeremy. Moving on then, it also adds on to this. It's part of the development as well. Place partnership terms of reference, Jeremy.
Thank you, Marie. Again, hopefully you can be brief. We brought these to the September meeting, I think, and there are a couple of outstanding queries. So we've just been taking advice, see what others are doing across South Yorkshire, and taking advice from our lawyers as well on the place partnership terms of reference for around 2 issues. One was the membership, particularly of place committee members, whether they should be members as well as of the place partnership board, and then on quoracy as well. So we have come to and it's in the paper on pages 81 of the main pack onwards, a couple of recommendations around that. So in terms of membership, we said to achieve consistency with other places and to retain appropriate balance in the place partnership membership, recommended that the CFO, Chief Nurse and Medical Director are participants when the partnership is considering business. But it is recommended that the independent NED, Leslie, becomes a full member of the place partnership board to bring out independence and objectivity to bear. And this would also increase the total membership from 13 to 14 and the ISP representation from 1 to 2, which is the equivalent of other main partner members as well. That's the first recommendation. And then the second was around what constitutes a quorum. All other places we looked at have used the 50% of the membership as a quorum, which Barnsley would be 7 people. Therefore recommended that the place partnership adopts the formula previously proposed by our lawyers Hilderson, that the quorum is set at 50% of the membership, including at minimum 1 member from each of the ICB and BNBC, and at minimum 5 members drawn from the other partner organisations. So I shared that prior to the meeting with Marie as chair of this group, and also with Wendy as the place director. And I think they were supportive. So if colleagues are happy with those, we'll be looking for your approval for those 2 changes to the terms of reference.
Thank you, Jeremy. Are we all happy to support that? Anybody not supporting it? Can't see any hands up. Yeah, we've got some thumbs up on the screen. When did you want to come back in? You're looking at me.
No, it's not that. It's not that I'm not supporting it, because I've already had the conversation. It's really about it's a question that you might want to answer at the end, really, or that we need to answer at the end. Are we at the point now where we can pull together that pack of information that can travel around the boards? Because I'm acutely aware individually that I haven't taken anything through to cabinet for such a while, and we must be getting to that point now where we can pull that pack together and schedule that consistent pack and conversation to boards.
Completely agree. So
yeah.
We got the finance group as a reference again. The second, Roxana picked those up. The final conclusion would have been, let's pull together that pack.
Yeah,
get it out to all with the generic pay-per-view to top and tail as needed. Yeah.
Yeah, that would make sense, and it gives a common message then across all boards, doesn't it, as well?
Yeah.
It becomes consistent. Okay, thank you. On that basis, then, happy to support the terms of reference. Yeah. Okay, thank you very much indeed. I would say, observation-wise, Barnsley, we are miles ahead of a lot of people, you know, so thank you to the team doing all the work and back at the ranch, so to speak. Okay, I'm going to move on then, and I know we've been joined by Angela Fawcett. Good afternoon, Angela. We've got annual report for children's safeguarding first, please. Is this Jane or Angela?
It's Angela Marie, thank you.
Yeah, okay, Angela, over to you. Thank you, Angela.
Okay, the paper's here for information. I don't know if people would like me to just pull out some highlights or just take questions. Yeah. I think I would say though that it's been quite late in being publicised, so we're going back to 2021 here, and things have moved on, and Carly's on call, and you know, I think we have moved on from when these annual reports were produced. There's been quite a few changes. But just in terms of highlights in this period, I think it's fair to say both boards were a challenging period to work in, but both boards maintained function, statutory duties, and you know delivered on standards really. Neglect has been a feature for children and adults and remains highest category. For children, there was a decision to make to focus on 4 key areas moving forwards. One of those was neglect, reflecting how significant the numbers are. Another one is bullying, which is an issue that's very obviously important to young people, and we were responding to voices of young people in taking that forward. Criminal exploitation and contextual safeguarding continues to be another area for moving forward and improvement, and generally service improvement. So there are four main areas that we decided to move forward on. we've had a JTI in the summer, people are probably aware, and from that I think there's some key areas as well that we need to move forward on, and which are reflected in annual report, particularly around capturing voice of child and acting on voice of child, and also making sure that we're escalating as agencies. So where there's professional disagreement or we don't feel we've got outcomes that are, you know, appropriate and in best interests of child, that all agencies are encouraged to use escalation process. In terms of some good news, we had 2 reviews during this period, both which related to unsafe sleeping, and we'd had quite a few. We'd had 5 child deaths in quite a short period that related to unsafe sleeping practices, including these 2 reviews. So there's been an awful lot of work gone on to try and improve that picture. There's been multi-agency working to produce guidance, training. We've done a public health raising campaign, and I never like saying this out loud, but since that work began, we've actually had no deaths where unsafe sleeping's been a factor. So going from 5 to 0 is quite an achievement. Obviously, it's difficult to correlate whether, you know, how much of an impact what we've done's had, but we're just pleased to be in that position. I think relevant to both boards has been a desire to increase referrals from public, particularly around adults, but it equally applies to children. So Safeguarding Awareness Week is this week, if people aren't aware, and there's a big push to promote people to report concerns, and that includes a radio campaign on Hallam FM. I think the challenges for both boards at the minute is looking at the cost of living and how that impacts on families going forward. Both boards are looking at how they can work in partnership with each other, but also the other partnerships and the boards across Barnsley, so like the Safer Barnsley partnership. So we're looking at that connectivity and how we can work better and avoid duplication and have clear leads for different areas. For adults, there's been an increase in referrals, most of them coming from health sector or residential or private carer sector. There's been lots of work on self-neglect and hoarding, and there's a very successful support group around hoarding that's been led by people with experience in hoarding themselves, and it's been very effective and well received. The adult board during the period of the annual reports employed a multi-agency trainer, which they'd not had before, and I can say that's been hugely beneficial in rolling out training across different agencies and helping to improve practice. It's something we've had in children for many years, but it's a new post for adults, and again, it's proven really successful.
Thank you, Angela. Really, really good reports. Anything any colleagues wish to pick up with Angela or indeed Jane? No. As ever, thank you very much indeed, Angela. Difficult area of work. I've got Carly actually just wants to come in there a minute. Carly?
Thank you, Marie. Just to say that work that we're doing in terms of interconnectivity, we've also got a sort of Children's Services Development Board going on as well. And I met with Jamie and Jeremy this week to talk about how we make sure that the place plan reflects fully sort of children's priorities. And then we're going to have a session in the next few weeks to work out how we streamline some of the governance, because there's quite a lot of different meetings with the same people talking about very similar things. So we're hoping to bring something back to this pod in January around how we do that.
Brilliant, thank you, Carly. And really important piece of work that for our kids, isn't it? So, okay, look forward to seeing that then. Thank you. Anything else from colleagues, either in the boardroom or online? No, I can't see anybody waving at me. Anybody waving at me? No? Okay, I'm going to move on then, if I may. Thank you very much indeed. And thank you indeed, Angela. Item number 5 then, preparedness for assurance adult social care. Dominic Armstrong.
Good afternoon. My name's Dominic, as you've said. I'm a service manager from the council for quality assurance and service improvement, and I'm here to talk to you about preparedness for CQC inspection. People might be aware that the Care Quality Commission are developing a single inspection framework, which will cover integrated care systems, local authorities and providers of care. This element today is primarily about local authorities and responsibilities in this area, but obviously that also covers integration as well, which is important. So slide number 2, the emerging framework. At the end of September 2022, the CQC shared this draft with us of the assurance framework and basically said, we're sharing this with you to help you prepare for assurance. This has not been approved, but we don't expect there to be major changes to this draft. There are 4 themes around which the framework is structured. The first theme, working how local authorities work with people, is primarily about adult social care, and it's probably the responsibility of the service director for adult social care. The second theme, which is around how local authorities provide support, is about commissioning, and is probably the responsibility of the service director for adult joint commissioning. The next 2 themes, third one is around safety, and the fourth one is around leadership. Those are cross-cutting themes which cut across all the areas. Slide number 3, how the local authority works with people, gives you a flavour of more of the detail really around what sits below these themes. Each of the themes has quality statements, which are made up of I and we statements. Those describe what good looks like from the perspective of people and families, the I statements, and the we statements describe what good looks like from the perspective of organisations who are supposed to be supporting people. Those have been adapted from the TLAP I and we statements. The main part of the slide is the best practice standards and guidance, and those provide a summary really of what good looks like in terms of best practice standards and guidance. At the bottom is the guidance itself relating to each theme. The CQC have been very clear in the briefings that I've attended that the Care Act will be the primary focus in terms of comparison. So they will look at what's happening on the ground, they will look at their sources of evidence, and they will compare it to the Care Act, reading across to other legislation like the Mental Capacity Act. Slide 4, how the local authority supports people, is similar, but one of the areas relevant to this theme is integration. Care Act is clear that to provide more integrated services, local organisations need to work in a more joined up way. Disjointed care can, it says, be a source of frustration for people and staff, and it can have a negative impact on people's health and well-being. As part of this, specific responsibilities are placed on local authorities to promote greater integration with health colleagues, and I believe that there's similar responsibilities placed on health colleagues in the legislation which supports NHS colleagues. The Care Act also gives some examples of what this might look like, and it references specific documents like the Joint Strategic Needs Assessment, like the Better Care Fund Plan, like joint commissioning arrangements, full budgets and integrated service delivery. Slide 5, the emerging framework. The left-hand side summarises the evidence which the CQC are going to use to sort of test the system. It's people's experience, it's feedback from partners, it's feedback from staff and leaders, observation, outcomes and performance data. The CQC will try not to, where they can, rely on a single piece of evidence to form judgments. They'll try and triangulate things. The right-hand side of the slide, what we've got is the proposed approach. The CQC have told us that for the first 18 months to 2 years, they're going to be establishing a baseline, and concurrently to that, they're going to be doing ongoing assessments, which will include inspections, which could start from the 1st of April next year. Slide number 6. Over the summer, the CQC released a questionnaire asking for views. We extracted all the information from that questionnaire. It gives us a good insight into the CQC's thinking and their evidence base, and we're using this to inform our self-assessment. You can see a summary of some of that information on this slide. So they are interested in a wide variety of things, including some things which I'm not sure we have, like an information advice and guidance action plan, etc. And that's informing our self-assessment. Slide 7 and 8 are about sequencing principles. So I believe the CQC attended a Yorkshire and Humber ADAS branch meeting in October, where they shared some of their thinking around sequencing. Obviously, local authorities and others are very interested in who they might come to and how they might decide upon those things. This indicated that local authority assurance, current thinking is that it will be a required evidence for an integrated care system assessment. Another principle around doing things once also points to an assessment window approach, which is demonstrated by the image on this slide. Last couple of slides. Slide 9, adult social care in Barnsley. We've set out some of the key strengths and areas for improvement, high levels of satisfaction from people and families. We've just on the verge of publishing our local account. On the 21st of October, the ASCOF data was released, which compares the performance matrix across local authorities. Barnsley is the best performing local authority in a couple of areas around carers and is the second or third best performing in other areas. And some of those measures are from direct feedback from people and families. So that's something that we appear to be really good at. Budgetary controls, we've managed to, unlike other authorities, have decent controls over our budgets in the last couple of years. We've had strong results from peer reviews, most recently a safeguarding peer review. We have a relatively low level of complaints, and we have positive feedback from staff via the recent social work health check. On the areas for improvement side, consistency of practice is a challenge, a real challenge. Management footprint on cases needs to be much stronger. Our management of service improvements from a quality assurance perspective needs to be better. We need greater grip and control over those things. CQC ratings of older persons' care homes need to be improved. The last time I looked, they were amongst some of the worst in the country. And we have limited scrutiny of some areas. The other issue is a lack of celebration of success, some of the things that we do well, which we're trying to put right. We had a celebration event on Monday, didn't we? With social work staff, where we were celebrating some of the excellent progress that people have made. Slide 10 is a summary of some of the things that we've done recently or are doing to get ready for inspection. Some of you will be familiar with some of this work. Learning from ADAS events, national pilots that we've been involved in and are learning from, a review of audit tools, etc. Some of the highlights on there. Lastly, some of the recommendations. They're not really recommendations, I suppose they're things we're doing. We're appointing to a grade 7 role to help us be organised for inspection so we can put our best foot forward. We are carrying out a self-assessment, which we're sort of in the middle of at the moment. And we're being clear with people about inspection rules and responsibilities. We're developing an evidence base to support that of some of our best practice. And we're thinking about, early in the new year, carrying out a mock inspection. That is it, really. Questions, observations, welcome.
Yeah, thank you very much indeed, Dominic. One hopes basically, Dominic, we never have to do mock inspections and tailor our answers before inspectors arrive, because we hope we are already trying to do our best anyway. But I think, like all CQC visits, we all prepare for them, don't we? So I think for me, I'll open it up to colleagues around the table. Is anything anybody wants to raise that Dominic's highlighted or informed us about? Yeah, Wendy.
Yeah, I mean, thanks, Dom, for bringing this in. It's you know, it's a family of inspections, isn't it, that we're all under, and in and of itself, it's a weight, isn't it? Let's be honest. And I'm not quite sure as yet how it's all going to land together as a holistic approach, and whether or not I saw that in the select committee recently that there was I know Rob Webster presented to that, Patricia Hewitt did as well, a real sort of challenge, I think, about the weight of inspection regimes across our organisations, really. So it'll be interesting on the back of the announced review of ICSs around autonomy and accountability, whether or not that gets sort of picked up, really. But I guess I just want to reassert what Dom said. We want to try and get to a point where we're putting our best foot forward. We're as ready as we can be. You're all cited on this, and are engaged in it. It's not something that's going to come as a shock to you, sort of like next year. And very particularly, just wanted to raise the point about the market John said that some of our I'm not sure it's as bleak as you painted it, but some of our providers are rated very good, particularly in care homes. Some of them have got a path to follow. But we do have the market position statement that we produced. I think the key will be about us all working together about defining what is the market we want to see together in terms of care, the care sector. We know we want domiciliary care working more closely around neighbourhoods and the neighbourhood networks, the PCNs. We know that we can't continue with this great effort that we've got in our system that's about those home first principles, which are really delivering. We had 1 month, not a couple of months ago, we had 1 month where we had no admissions to residential care. And now I think that's right. But that means alongside of that, we'll have a failing care sector who won't struggle and we'll get closures and all the rest of it. So getting a grip of the shape of that market and working together on it, I think it's going to be really important.
Absolutely. Thank you for that, Wendy. And thank you, Dominic, again for the continued hard work. There's a lot of work behind these inspections and we really appreciate the presentation today. So thank you, Dominic, and good luck with that. And if partners can help in any way, we're always there and we will. Thank you.
Adrian,
sorry, Adrian. Yes, you want to come, Adrian? I see you waving at me, Adrian.
Just a comment, Chair. How much you're fortunate to have someone who actually works with the CQC and is working with Julie Chapman to promote inspections going forward, so that we can actually hopefully be ready.
I'm meeting with Mark tomorrow.
Very helpful.
So keep you on your toes.
We all need an Adrian, is what I say, Adrian. Thank you, Dominic. Appreciate your time. Thank you. Okay, moving on, FMA then, the Barnsley Place Partnership Delivery Group. Jeremy and James, please.
Hi, Jeremy. Do you want me to do my bit first and then I can hand over to you?
Yeah, that's fine, yeah.
Brill. So I have got a paper which I'll circulate with the minutes, which just gives an overview of the things that we've been discussing over the last month. The sort of highlights to share are the preparation for the overview and scrutiny committee, which is next week, with a focus on integrated care and primary care. There's been active discussion around a jointly funded public health analyst post that would be there to support the system, and we'll be revisiting that to make sure we've got the right decision on that in the next couple of weeks. We had the first larger monthly meeting focused on the PMO, which Jeremy talked about at the previous meeting, so I won't go back over that. And then we also continue to use the meeting as a weekly sort of sense check around system pressures and how we can support each other. So again, one of the examples of that that's been discussed this month around has been about OPAL levels and how the instigation of those affects the rest of the system, and how do we work to escalate things as a system rather than as individual organisations. So again, that's a positive step forward. So that's a brief overview of the things we've been focused on for the last month.
No, thank you, James. Jeremy, I know you've already talked about the delivery unit a little bit, but is anything else you want to add?
No, there isn't. No, so I did a brief update too. James and I didn't manage to get together to coordinate our brief updates this time around, but we'll try to do that in the future. But we've covered off the same points pretty much, so that's good news. So no, I think that's been a lot of questions. That's complete.
Okay, I mean, I've got a couple of questions, but I'll ask them outside the meeting because there's a few things here about the delivery unit. And if it's going to be a delivery unit, we probably need to think how we bring some things like, you know, that the autism group, some of the things we've talked about today about quality and safety report and some of that into the delivery group. But I'll pick that up outside if that's okay. Anything else from colleagues then about that? No. Okay. I'm going to move on then, if I may, to the dashboard for Barnsley highlights and exceptions, please. Jeremy.
So again, if it's okay with colleagues, we've got the dashboard in front of you. Hope you had a chance to look at it. Andy's actually been through the most in-depth part of it already in his presentation earlier, which was looking at system pressures. So we've already covered that off. That's part of this pack as well. It's there for you to look at. There's some top lines on page 128 of the main pack, highlighting some of what is within the quite detailed dashboard. On page 129, there's a summary of things in the graphs and charts that we have, where things are either in line improvement below target, off target, or outside expected variation. Now, you could have lots of questions about this, and indeed I have. What I've suggested that we do is we use our monthly PPTG meeting to look at this in a bit more detail. So when we come here, we can escalate things appropriately to you, give a bit of commentary to all these areas. So I'm not going to go through it today, but that's what I've agreed we'll do in our monthly PPT session as we look at our dashboard, which will evolve over time as well. So we are escalating issues here where we think action needs to be taken or things are off plan. Hope that makes sense to colleagues. Otherwise,
yeah, I think it does, Jeremy. I think it does make sense. I think it's like all dashboards; they're only as good as you actually use them for. And I think there is a bit about how that dashboard evolves, and if we are going to make decisions on dashboards, then we need to be making decisions on them, not just presenting them, if that makes sense.
I agree.
Richard, yep. Please, Richard. Thank you.
Thanks. Just picking up the ambulance bit. I mean, obviously, it's a big cause of concern nationally, regionally, locally about ambulance response times. I've, in my other role as the chair of the UEC Alliance in South Yorkshire, I've asked Yorkshire Ambulance Service if we can get ambulance response times broken down to place, because I think it'd be useful for us in Barnsley to know what the local response times are, so we can sort of see how that correlates to what we do. So and he says he will give them me, so, and I believe him, so they might be available. We could choose to put them in this dashboard if you wish, Jeremy.
Yep, that would be useful. Thank you. Can do that. Can we do that now?
No, we can't do it now. We used to be able to get it at Barnsley, but probably 5 years ago, and then it stopped and came together at system, didn't it? And it's never been very helpful ever since.
We did hear though, didn't we? Sorry, Marie. We did.
Yeah, Wendy, go ahead.
Yeah, we did meet. We did hear from the meeting, didn't we, this morning from Kieran Baker, developing BI, is about having a real live system dashboard. I think that's been developed at quite some pace. Richard, as I understand it, I haven't seen any draft or any of all that, but that's about really bringing live information together across a number of different organisations. So you might be more aware of that progress than me.
Richard?
Yeah, if I can come back on that. So I think the live dashboard is part of these sort of winter control group, system control, command centre approach. And I think that may or may not be helpful in a day-to-day operational sense. I've got my doubts, but I know Kieran's well on with that, and I think he's going to try and use the data we already have, which makes a lot of sense. I think what we should be focusing on, though, is not that. I think there's a real danger getting sucked into the day-to-day stuff. We should be looking at trends and big picture stuff and thinking what we need, what pieces of work do we collectively need to commission and deliver that will then have an impact on those day-to-day things. So whether it's, I note in here, UEC attendances, people with mental health conditions, for example, which is a problem in many areas. So, we need to take a more strategic look, and I think it would be counterproductive for this group to be looking at, immediate operational details.
Thank you, Richard. Anybody else want to come back on that? I fully support that, and I'm sure colleagues would as well, Richard, about the use of a dashboard and SPG charts in particular to start forecasting through problems as well. Okay, excellent. Well, thank you for that in terms of the highlight report and exceptions, Jeremy. I'm going to move on then to Barnsley Plan PMO highlight report. Jeremy again, information and assurance.
Got my name on it, Marie, but it's not just me. It's a shared responsibility. So there's a very, very brief highlight report. We've already touched on the fact that our Place Partnership Delivery Group is looking at our plan for 23-24 and agreeing what those key priorities are that we want to work on collectively together. And then part of the work then is to review our PMO arrangements and make sure they are operating effectively and are adding value when we come together. What we've done is therefore taken a slightly different approach for this report. We looked back over the last couple of months and sort of pulled out some of the key highlights of things that have happened over the last couple of months, and that's on page 156 and 157 of your pack. So I just thought it's a useful thing to do. This isn't perfect, and I'm sure we will have missed some things out, but it doesn't take very long to do to pull this together. We just thought it's useful just to be able to show to ourselves collectively that, you know, from all the work that we're doing together, there have been some notable achievements over the last couple of months. I'm not going to pull any of them out over one or over the other, but really looking to you to see whether you think this type of approach is useful for us to work on and bring to this board.
Thank you, Jeremy. Any colleagues, comments? I think it's useful because I think if we forget what we're doing, actually, I think it's actually promoting the work that's ongoing by our staff, but I don't know what other people think. I think we're getting a lot of nods on the screen. I'm assuming we've got nods around the table, Jeremy, or not? Or are they all sitting there blank-faced? I'm sorry, I can't see any of you. I apologise. I'm not being rude. I can't see any of you.
Nods.
You're not blank then. I can see my colleagues on the screen. Okay. So I think in supporting Jeremy, I think it's helpful. I think my colleagues are saying the same. Is that okay? Yep. Okay. Thank you, Jeremy, for that. I'm going to move on then, if I may, to finance and performance. We have no items on there today, I'm told. In terms of the minutes, we have the minutes of the 9th of June 2022, an escalation to Health and Wellbeing Board. Again, this is for information and assurance. Wendy, do you want to come back on that?
No, there's nothing at all for me here. Unless, do we have any escalations? I guess that's the question. Do we have any escalation to our Health and Wellbeing Board at all from today's conversations? I don't observe any. Nobody's asked for any.
No. Okay. Finally, then, the reflections of the meeting. Before I open it up, a couple of things for me, if I may. Apologies for it's very difficult to chair on Teams and be hybrid, and I don't know what people think of that. So that's my fault and my secretary's fault that I'm not there. So I think that's one thing that won't happen again from my point of view. Second thing for me, Wendy, it's maybe something we need to pick up outside. When I look at item 10 on your agenda, item 11 and item 12, I'm struggling to see if they're partnership papers, we should be talking about that in the partnership board. And I think there's a massive crossover, because I think that discussion we had in your part of the agenda, they're really important partnership discussions then. And it's knowing where to place things. Or do we have a rethink, Wendy, about placing anything and just saying, yeah, these are the statutory bits and these are not, because I think it's working, but I think it could be a bit smarter for me. I don't know what colleagues feel.
Yeah, I mean, I would certainly agree with that, Marie. I think we started off with this construct, which almost feels somewhat artificial, to be honest. So I think it's time for us to take stock of it really, and think about just more of just a steady flow and how we might construct it, but play regard to the obviously governance, roles, responsibilities. I think we can do that.
I
do.
Jeremy? I mean, well, now we have agreed the terms of reference. We're clear about who's our participant, who's a member. We just need to be clear if decisions need to be taken, whether they place committee decisions or place partnership decisions. Then we have one agenda with just clarity around decision making in it.
Yeah, I agree with that. So our colleagues around the table and on the screen, are you happy then outside the meeting if I have a conversation with Wendy, Jeremy et al, and let's see if we can actually try and get this construct into one meeting agenda, because I think it would appear to make more sense, and for anybody in the public who may attend, it's less confusing possibly. Would you be happy to do that? Yeah. Excellent. Okay, on that basis, I'll take that as an action for myself and Wendy then, if that's okay with you, Wendy. I'm looking at you on the screen. Yeah. Any other reflections from colleagues today?
It's pretty compact, isn't it? Maybe it just comes to the forward plan again, and we need to think a little bit about the forward plan really, and the balance of the time that we give to items. So I just think we need to think about that.
Yeah, I think we could have some of the actions could have been a bit longer. And I think when you've gone over, Wendy, I think it was quite legitimate, to be honest. That discussion had to happen. It wasn't, you know, you can't rush these things sometimes. So I'd agree. So we'll have a look at that outside as well. Okay, on that basis then, thank you everybody for that. Date and time of the next meeting.
Marie,
sorry, Wendy.
Sorry, Marie. I did want to introduce an AOB from Bob. I think given the context of the, on Bob's behalf, given the announcement around the strike action, and of course, you know, Barnsley Hospital is a participant in that strike action, it's helpful to Bob just to give a bit of a very brief note.
Yeah, so, you know, everyone's aware of the strike situation, of the sort of complexity to what's going to be a difficult winter. Just the clock's ticking down the ultimatum now at the moment. There's a bit of a face-off between government and the RCM, but Barnsley have voted to strike. And I think there's more votes to follow. I think it's important to remember that it's you know, an action by unions and staff against the government, not against organisations. So we actually work quite well with the unions in terms of getting the balance right, looking after staff's interests, but sort of thinking about the quality of care as well. So we have had some previous experience. We're working with a readiness plan around the strike contingencies, and just to make it even more helpful, there's a checklist come through from the centre this week as well for us to get signed off this week to make sure we do it. Who knows how, you know, we'll see how it goes, but we'll keep people informed of it all.
Okay, sorry, Wendy, I was going to close the public meeting off and then move into any partnership updates that were confidential nature, but I think that was appropriate for that update there for our public members. Marie. So on that basis, then I will close the public meeting off. If colleagues can stay online and in the boardroom for the private part, which will follow, which will take no more than 10 minutes, I'm assured. But actually the public meeting will be finished, and next public meeting of the Partnership Board will be on Thursday, 15th of December at 2:30 in the boardroom, Hillender House in Barnsley. Thank you very much indeed. So on that basis, the recording can stop for the public meeting. Thank you. Okay, are we clear out of public meeting? Are we stopped recording that? Wendy, I'm looking at you because I'm not in the room.
2 minutes.